All right, we good?
Yes.
Cool. All right, so let's put that up there. So, OB, maybe. We're loading. Um, Babies. Uh, Pregnancy should always be considered for female patients of childbearing age. This is kind of something we drill into everyone from the BLS level on because it's kind of a pertinent item to ensure that you think about. Um, so we say that like the average age of menarche in the United States is around 10 to 12, but there are some girls who actually do get their period earlier, around 8 or so, based on the fact, or due to the fact that we are kind of pumping our food full of hormones and all sorts of other nonsense. So it's really skewing the way that female reproductive health is going. Also, we are in a land of plenty. So that those extra calories that are easily accessible to everyone makes it better for the like a female's body to actually start the whole process of menstruation, which means that you're overall more fertile than the French peasants of the 1600s. It costs a lot of energy for the body to build a human. Okay, so back in the day, it was a lot more difficult for women to get pregnant because of that. And it was a lot shorter of a span. These days, women can have, a lot longer of a reproductive health like lifespan. Whereas you have girls who are starting their period at 8, and you have, women in India who are giving birth at 72. So it's always something that you should consider. You need to find out, and if you are dealing with an older woman, you need to ask them if they are still having their period, and if not, when is the last time they had their period. You, as a female, need to be 1 year without menstruation to be considered postmenopausal. Okay, so if a woman says, oh, my last period was 6 months ago, I'm postmenopausal, there is still an outside possibility that she is pregnant. Okay, so just keep that in the back of your mind. Maybe don't break that news to her because she might be very distraught with the idea that now she's going to be, 55 years old and pregnant again. Heartbreaking, right? That's another 18 years of commitment. In the grand world of reproductive anatomy, this is kind of what's going on. You'd be really surprised with the number of adult humans in the United States who don't understand what a female's reproductive anatomy looks like, or how it works. So, other than actually educating our children in sex ed, here we are. Let's talk about it real quick. So, right, so you have the vagina, which is considered the external root. It is one of the other really terrible terms that I've heard is it's the
Question.
canal for the penis. Go ahead.
Did you explain how they can get pregnant before they have their first period?
Yes, I can.
And
So, great question. So, in order to have a menstrual cycle, an actual period, an egg needs to be released from the ovary through the fallopian tubes and then fail to implant in the uterus. So before a girl actually gets her first period, an egg has been released. And when that egg is released, if in the event that a sexual act has occurred, there is the possibility that she can in fact become pregnant. It's all about timing. And it's kind of hard to kind of time that appropriately. Not that you really want to be engaging in sexual activities with 8-year-olds, but it does happen on occasion.
okay, so it's just the development of the egg.
Yes, exactly, or the fertilization of the egg.
Okay. Cool.
Great question though. So if you kind of look, and I don't know if, hold on, I like my little. Let me see if I can, come on, there we go, my little annotator draw. Okay, so we have the vagina here. Medical textbooks can describe it as a canal for the penis, which makes me cringe, honestly. Just, ugh. it's like an anatomical functional part of the body. It's really not just for like a male's pleasure, just the sexualization of that in so much as making it because due to a man's thing, not a lady's, anatomical feature is frustrating, but women's rights. So basically the uterus sits just kind of over the bladder. The vagina here is kind of designed, yes, for reproductive purposes, as well as to allow the baby to be expelled from the body, but it's also so that the byproducts of failed fertilization and/or menstrual cycle, right, that blood and tissue and mucus that is the lining of the uterus can be discharged from the body, because there are times if there is some a lack of an opening here that can back up and a woman can become septic. It's kind of rare, but if for example, if a girl's hymen is still intact, or the vaginal opening is not fully open, because sometimes it happens, there's just a developmental issue, all of the blood and the tissue and stuff that is being discharged will potentially build up and make her very ill. It's again one of those rare things that you might see here and there, but still a possibility. So you have your ovaries and your fallopian tubes, which kind of come down. Then they, like, one of my favorite, right? So you have your uterus and your ovaries and the fallopian tubes, and the uterus just looks like it's angry and gonna fight you. So they kind of float above the bladder, which is why when women get pregnant, they're like always going to the bathroom, because now you have this big old pumpkin head smushing on a bladder. Just not it doesn't look fun. So the urethra, and this is one of the reasons, kind of sidetracked a little bit, but not terribly. Your urethra is, obviously the pathway for urine, but it's also very close to the vagina, so there's a lot of possibility that vaginal flora can end up in the urethra, and this is one of the numerous reasons that women are more prone to UTIs than men are. Another fun aspect of female anatomy is the Bartholin's gland. We talked about this a little bit last week, but they are lubricating glands that are on either side of the vagina that kind of live in the vulva. And they produce, as I said, lubrication. So if they become, the duct for this gland becomes blocked, or there a small bacterial infection happens, these can kind of blow up and become inflamed and cause a lot of pain for a woman. We're going to talk a little bit more about the progression of a baby's development, but traditionally, you kind of see when a female is pregnant, because she has what we call a gravid abdomen, right? So you can see the baby pushes out. A number of other things also occur during pregnancy, which we will talk about briefly in a moment. So just like Ben asked, fertilization occurs in the fallopian tube. The fallopian tube is this fun little pathway that goes to the uterus, allows the eggs to get from this little magical floaty island here through to where the business portion of reproductive growth happens. I've lost my here. If a fertilization does occur, it happens about 7 days after fertilization, because usually fertilization will happen in like this region in the fallopian tube. And it doesn't sound like that's like a really far journey, but it takes about a week. In the event that that either fertilization happens like down here, or it moves a little slower than anticipated, there's the possibility that that fertilized egg can implant inside the fallopian tube and cause, obviously, an ectopic pregnancy and all sorts of other issues, like surgical emergency issues. When it is originally fertilized, it's called a zygote. As it starts to split into multiple cells, it's called a blastocyst, and that blastocyst becomes the embryo. Okay. There's a portion of it called the tryptoblast. Okay, these cells are specialized cells that become the placenta and the amniotic sac and the umbilical cord. Okay, just tidbits of information that you are probably not going to need to know. But always good to have that extra bonus info. If anyone says, or you ever see a question that asks what are the specialized structures of pregnancy, these here three are those things. The placenta, the umbilical cord, and the amniotic fluid, right? They serve very specific functions for a very specific period of time. The placenta is a sort of a filter between the mother's blood and the baby's blood in order to prevent like that cross-contamination of blood. Excuse me. But it also produces a number of hormones that allow the pregnancy to continue. So if the placenta is not healthy, then there's a strong possibility that the baby will end up being a miscarriage. The amniotic sac and amniotic fluid is sort of like a shock absorber for the baby. It to the point around where the baby is born, that amniotic fluid sort of shifts from being purely amniotic fluid to mostly baby urine, in case you were really concerned about what that was consistent of. And the umbilical cord is, again, it attaches to the placenta and it provides oxygen and nutrients from mom to the baby, and then reduces or relieves the waste from the baby. And here we are talking about it again. Placenta is like kind of disc shaped. I don't know if anyone has ever played or with the birthing mannequin, but it's kind of like this round, spongy. It's gross. It looks like a giant blood clot. Let's be real. It's really kind of interesting. So what it does is it creates this when it embeds into the wall of the uterus. Hold on, my little. So you have the wall of the uterus, right? So that's here. And the placenta kind of comes and attaches, very a la horror movie alien sucker face hugger guy, right? So it kind of attaches to the placenta or to the wall of the uterus, and it creates this like squiggly interface between the wall of the uterus and the placenta itself. Okay, so it's like you have this like kind of like squiggle here, and there's a capillary bed in between here. So remember, like when you have your alveoli and you have that capillary bed, when like oxygen can go from here and in here, and CO2 is going the other way. Kind of the same concept, but inside the uterus. So again, you have from the placenta, the baby's going to have like carbon dioxide, and it's going to send it out to mom like, hey, I need me some oxygen, right? And she's going to send the oxygen back in. And then there's going to be some nutrients that's going to go in, and like waste products that go out. Okay, so it's very similar to the capillary beds that we see in all the other aspects of the body, where you have that waste, the nutrients, waste, oxygen, carbon dioxide transfer. It does allow for a certain level of protection for the baby, similar to the blood-brain barrier that we talked about in like neurology, where certain items cannot cross into the fetal circulation. It's a protective barrier. Unfortunately, there's plenty of things that do cross that are still damaging to the baby. For example, alcohol and narcotics. The umbilical cord is unique. Just like pulmonary arteries and veins, the vein carries oxygenated blood and the arteries carry deoxygenated blood. Okay, one of the few locations in the body where you will see this mismatch. Okay, so this is I've seen this state question a number of times. What does the circulation for an umbilical cord consist of? It's one vein, two arteries, and the vein carries oxygenated blood while the arteries contain deoxygenated blood. You can see right here, if you look also, which is kind of cool in this cross section of the umbilical cord. So you see right here, that's the vein. Look how kind of just like smooth and non-muscular. Like, when you look over here, look at the artery, and you can kind of see like right here is like one of those muscles that help control the pressure that you experience, right? Because remember, arteries are high pressure. So it's just kind of really cool that you can see that difference and Well, that's kind of what happens in the rest of your body as well, in terms of your vasculature. So amniotic fluid, again, we kind of talk about this as being the shock absorber for the baby. If anyone has ever seen how they produce shocks for a car, right? There's if they're hydraulic shocks and not gas shocks, there's all that fluid in there and it pushes in to kind of cushion the blow of like potholes, etc., etc. Kind of the same concept here with amniotic fluid, right? This baby is floating in this fluid, so like if mom bounces or jostles, the baby is just kind of like chilling, right? In this like really zen float space. There's approximately 175 to 225 milliliters of amniotic fluid at the 15th week and about 1 liter at birth. So when a woman's like, "Oh, my water broke," it's like a liter of fluid. It's usually pretty significant. The amniotic sac does not always rupture during the process of birth. It occasionally will just remain intact and will need to be actually ripped open by whomever is delivering the baby. If the amniotic sac has ruptured and labor persists for over an hour at that point, there is a high risk of complications, usually fetal demise, where the fetus is really struggling because of the lack of blood flow. Because think about, once that uterus starts to kind of compress, it also puts a lot of restriction on the blood flow of the placenta as well. And a high risk of infection for mom, okay? Because again, the body's starting to kind of be exposed to not only the amniotic fluid, but like the byproducts of baby, which is like, you kind of have that transplant rejection vibe because it's a whole new, brand new, unique individual. 6 key hormones that you'll see during pregnancy. Progesterone and estrogen, which, yeah, this is a British infogram, so it's spelled in the proper British way, with estrogen has an extra O, are always present in a woman's body, but the proportion in which they are found is different during pregnancy.
Nicole,
Yeah,
very quickly, I'm sorry.
sure.
Just about amniotic sac. If we were, I mean, if we have access to it and the baby's coming down and it's not broken, how difficult is it? You just do it with your fingers, right?
Yes. I have
And
never
how?
had to deliver a baby whose amniotic fluid or amniotic sac has not whatchamacallit, ruptured. So I don't know how challenging it is. I don't know if anyone actually has, but from what I understand, it's pretty easily broken with fingers or,
Okay, got it. Thank you.
no problem.
Yeah, Joe. It's they have to do that with my wife, and the doctor just used her fingers.
Okay, got it. And so one follow-up question to that. We would obviously see that. I mean, instead of the baby's head crowning, we would actually see, the sac wall somehow.
So the sac is very thin and kind of transparent, so it might just kind of look like there was like saran wrap or something kind of over it. Just not as shiny, I guess, is
Got
a
it.
good way.
All right.
All right, hold on one second. I'm having a phone call I have to take.
No worries. If you
Hello?
can hear me, Robbie Davolo, turn your camera on, please.
Hi. What's up? Hello.
I'll jump in really
Okay,
quick
hey,
while
what's
Nicole's
up?
on the phone. Some babies are actually born in the sac, so they actually
Okay,
come
so-
out completely. It's really rare, but it can happen where the baby's still in the sac
thing?
and the baby can be fully birthed,
Delightful. Okay.
still covered in the amniotic
Alright,
fluid,
so
which is pretty
project for
cool.
later.
If you guys look it up, some good images
Okay, thank
online.
I was literally sending an image in the group chat of that.
Yeah, it's really interesting to see, actually.
I've seen
All
that
right.
like in C-sections. They when they're having a C-section, they just take the whole sack out too.
Oh, just wait till you do your OB rotations. For those of y'all who haven't seen childbirth yet, a C-section, freaking barbaric. Okay,
It's disgusting.
it's horrible. It's like
While he's eating.
If you
with
there
DMS.
there was a video of a bariatric woman getting a C-section, and they actually had to pin her abdomen to the behind her because it was so much fat.
Oh my lord.
Disgusting. Yeah.
Yeah, no.
Both my kids with C-sections, and my wife's intestines were on her chest, and it was the most.
Yeah, no, it's. I don't know why they took her intestines out. Why they take those out? Those aren't supposed to come out.
I don't know. The doctor. I don't want. No.
Yeah, no, I saw they took this lady's full uterus out and like slapped it on her stomach and then cut it open. I was like, oh nope, I'm out. And my husband like is confused as to why I'm not like, let's have babies. I'm like, I was traumatized like that. And they like, they do the incision, and then instead of just cutting like the skin a little bit more, they were pulling on this woman's freaking like surgical incision to make it wider. And I was like, I'm gonna go with a nope on this one.
So if you recall, if I can just kind of incorporate this into this discussion very quickly, we did that discussion group way back in the beginning about cesarean sections. And of course, me being the history buff, cesareans go back like to Caesar. That's why they're called cesarean sections. Like to 500 BC, they were cutting women open and successfully withdrawing the child. Sometimes the mother died, sometimes they didn't, but that goes back way back.
Yeah, and it hasn't gotten any less barbaric.
Yeah.
And I don't think that in the United States the maternal mortality rate has improved any from the time of Caesar, unfortunately. The problem, so sidebar, the problem with OB in general, not even in the emergency setting, is hemorrhage. And most hospitals, the labor and delivery unit is the one unit that does not have bloods in stock, like available, and two, is also the furthest away from the blood bank in most hospitals. So women will start to hemorrhage, and they're like, hey, I think I'm hemorrhaged, like that, I don't feel good. And they're like, no, you're fine. The little blood is normal. But it's a lot more than anticipated because, again, remember, we talk about this abdomen is, a really good spot to hide blood. And then you have a more or less a deflated, you just took an 8-pound baby out of an abdomen, and it's kind of deflated. That's like 8 pounds worth of space where blood can hide. So it gets missed very frequently, and they don't have bloods at the ready. So there are plenty of women who hemorrhage to death in the labor and delivery unit because there's no bloods available and they don't act quickly enough to fix the hemorrhaging issue. Back to C-sections a little bit. Go ahead.
I'm sorry. Doesn't the bladder also rupture easily too, and they hemorrhage like crazy fast from that too?
Yeah, it's a lot of women, if in order to stop the bleeding too, they have to take the uterus out. So remember, we talk about that capillary bed between the placenta and the uterus. Very, very vascular. Uteruses are super vascular. That's why they can grow babies. So just everything in that area just can be damaged really, really easily. But back to C-sections right now. Remember Charles Darwin, gentleman extraordinaire who brought us evolution. When we started doing C-sections, we started allowing babies of larger birth weight who had otherwise would not have survived to start to propagate, because now we were just taking them out and saying, no, they're good, right? Because otherwise they would have been stuck and there would have been fetal demise and possibly maternal demise. But now we're over here like, we've got it, it's fine. And we have essentially halted human evolution, or altered the course of human evolution by overdoing C-sections. Not to sound totally kind of coarse and awful, but that seems to be, now we have all of these babies who otherwise would not have survived. Another thing, like babies who are just brought to you by planned C-sections because of doctors who can't be bothered to wait around for the baby to be properly cooked, is also seeming to be a pretty significant issue. Because now they're not being exposed to that vaginal flora, so they're getting more sick because their immune system is not as strong. So it kind of brings us back to the Jurassic Park, is like, just because you could do it doesn't mean you should have kind of vibe.
How hard is it to give a baby vaginal flora? You just grab some and just slap it on their face.
That sounds horrendous.
Jordan, could you do that to all 4 of your kids?
He's the professional.
Yeah, this is. He definitely he helped. He helped his kids. He's like, "Here, how you doing?" Butter like peanut butter you up.
Ask him why his 4th kid came out with a backpack ready for school.
He's already reading at a 2nd grade level. Anyway, so the other hormones, right? So that are involved in pregnancy, we have the HCG, which is the hormone that they actually use to detect pregnancy in like the pee on the stick thing. But if you look at where that hormone starts to kind of elevate, right? It's around like the 5th, 6th week, where like if you take a pregnancy test in weeks 1 to 5 of your pregnancy, you could get a false negative. Which is really kind of controversial also if you consider the way that they've been trying to change abortion laws in the United States, especially places like Arizona, where you can't have an abortion with, after week like 10. But there's a lot of women who don't even know that they're pregnant at that point. But that is a political question for another time. Dahaha! I've killed another of the mosquito swarm. Jesus.
Well, now with the morning after pill, though, I mean,
Ah.
you know, and just throwing that in there. I mean, and I don't want to politicize the discussion too much, but haven't you really just provided like the substitute for the pregnancy test?
Nay. So the morning after pill is the same exact hormones that you find in birth control, just like it's progesterone and estrogen, just at a much higher level. So it's kind of giving the body the idea that it's in like that 35th week of pregnancy, where it's like, oh, okay, like we don't need to ovulate right now, but if you've already ovulated, it's not going to 100% prevent implantation. It all depends on the timing of when the hormones are taken. So, and where a woman is when she's had sex in her reproductive cycle. So if she is ovulated and then it's been fertilized, and it, you take the morning after pill, there's still the opportunity for that egg to implant. It's not as, unfortunately, not as effective as one would think. The backup problem is, yes, there's a lot more access to birth control, as provided you don't work for a Catholic institution, and they don't repeal part of ACA. But the bigger issue is now women don't know how their body works, so they don't take birth control correctly. Right? For example, how many people, I only take the birth control when I'm having sex. Okay, it's not a condom. It doesn't work like that. It needs to be taken consistently in order to reduce the hormones that are being produced, because that's essentially what it does. So hormonal birth control takes the progesterone and estrogen levels and drops progesterone particularly to a very, very low level where the body is practically postmenopausal. Okay, so it doesn't have, it is incapable of producing enough progesterone to encourage ovulation and then maintain a pregnancy. But if you don't take it consistently, you can still get pregnant. So it's I don't 100% disagree, but I do agree that access is still an issue to a lot of women in parts of the country. In New York is not a good example because we are extremely liberal when it comes to those kind of things, where, access to birth control, access to doctors. If you go anywhere in the South, good luck finding a doctor who will write birth control prescriptions. Good luck, in some of these poverty-stricken areas, good luck finding someone who has access to birth control, money for birth control, or even to just go to a doctor to get the prescription written.
One of my friends used to do like her clinicals in one of the high schools in Brooklyn, and they used to just give them out in like the school nurses' offices. Like people would just come show up and say, "Hey, I had sex yesterday," and they're just like, "Okay, here you go."
Yeah, really?
Yeah, it was just that easy. That's what she always told me that.
And that's a New York state of mind right there. But it's really interesting too, because if you look at the larger picture, if you have a younger population where you have women who are having babies at an earlier age, one, they're actually at an increased risk for complications from that 17 to 19 age group. And two, you actually lower the country's economic stability because you are basically taking about 50% of your workforce out of the picture, which is just, it's really interesting. If you look at countries that have increased access to birth control, increased sex education, they actually have a higher gross national product, which is just interesting from like a larger perspective. Yes. So.
Oh, sorry, Nicole.
Go ahead.
Two tidbits of information. I'm not sure if it was like an overgeneralization, but I know because I lived in Texas for a year. Like there was like a Planned Parenthood, because I know there's like the whole like, oh, there's not really access, maybe not as much comparatively to other states, but it's not like there's like a big no for the state.
It also depends on where you are. So if you're in a major city, you'll have increased access, but they've also defunded a lot of Planned Parenthoods in the United States in the past 3-4 years, which is kind of unfortunate because Planned Parenthood is actually a lot of women's access to even just pap smears. They kind of rope it into, oh, it's just abortions, and it's not. It's birth control, it's overall health, but yeah, no, it is kind of a generalization. And if you look at the way that the legislation is moving, a lot of places in the South, and by the South I mean south of the Mason-Dixon line, are moving towards very conservative legislation where it's really restricting women's access to things. Texas is still on the more liberal side. But that's, I think, also because there's a lot of New Yorkers and like East Coasters who kind of moved to Texas, and Californians who moved to Texas. But if you go to like West Virginia, good luck. Alabama, Godspeed.
And the second thing, I threw it out in the group chat just to make sure. Quick little thing. Soraya, Matt, other Matt matters today. Confirmed through the email from Scott, and he just wrote in the group chat right now.
Okay. So it's confirmed. So you're still going.
What? You are going to Matt. You are.
This is an emotional roller coaster of a day right now.
Recent update. Most recent update. Check the chat on the Zoom and also anywhere else. You are going to Mather. Be there at 3:00.
The dumbest shit.
That's right.
Oh, I'm not on mute.
Yes, in case your emotions weren't being toyed with enough. Now you are still going.
So,
go ahead.
One more thing on the birth control thing, as I understand it, because I've been around for a little bit, birth control access for women has been really a recent development, has it not? I mean, we're talking about recent 60s, like maybe. If that, maybe a little earlier, but
so yeah, I want to say probably around the 60s, and there's still some issues with it. So one, in the 60s, yes, there was a huge movement for women to actually be able to start to access birth control, but there was also a huge issue with birth control because it was a little bit on the dangerous side. The amount of hormone that's in the birth control and the pill right now is significantly less than was in the original pill. The original pill was causing like extreme hypertension for women. It was causing blood clots. It was not super safe. Come to 2000s, the 2000s. There's other things like the Assure, which is actually like this weird little spiral stent that they put in, in the fallopian tube, which is supposed to cause like sterilization. It's like an alternative to tubal ligation, where it causes scarring so that the egg cannot pass through the fallopian tube. And despite the fact that it's been FDA approved, a number of women have had significantly awful side effects to it, including needing to have parts of their intestines resectioned because it wandered, because it doesn't stay in the fallopian tube. So they found it in people's hearts, in people's lungs, because it has gotten out of where it was supposed to be and kind of gotten into the bloodstream and gone whoo through the body to other places, primarily the abdomen. The biggest problem right now with birth control is in the Affordable Care Act. One of the really great parts of that is that it was required that that birth control was to be covered for free if you had health insurance. And then you had the Catholic Church who was like, no, we don't believe in that. We can't support that. And don't get me started on the Catholic Church. Because, you know, it should be a woman's right to decide what she wants to do with her body, and not necessarily having to rely on a man to either A, use a condom, or B, use it appropriately, or C, not tamper with it, because there's plenty of documented pregnancies where, you know, he decides he wants a child, or he wants to entrap this woman into being with him forever, and just, you know, puts holes in the condom, and vice versa, because there's women who do that to men as well. Not to say that one party is more guilty than the other. However, the problem with that is now you have all these places going, oh, well, we don't have to cover it. Oh, it brings up the whole ongoing women's rights debate where we shouldn't let women make those decisions. We clearly are just not responsible enough. You're too hysterical. Yeah. So, for example, like if you are a married woman, and I'm going to have my little shout out to RBG right now, she made it provided women with the opportunity to access birth control without their husband's permission. Okay?
The real MVP.
The real MVP, the notorious RBG, because there was a point in time where women were not allowed to get birth control if their husbands did not consent to it. Now, disregarding women who are in a safe relationship, what about women who are not in a safe relationship, who are in an abusive relationship, who, you know, don't have a husband who, you know, maybe he's extremely religious and decides that I don't care, we're going to have as many kids as you can pop out, kind of thing. So it eliminated that previous ruling eliminated a woman's right to her own body and her own autonomy. Even now, like if as a woman, and you think if it's even as a man, I think it's more on the women's side. If you decide you want to go get a tubal ligation and you're married, one, you have to get consent from your husband because maybe he wants to have more kids. Okay, that's great, but like, and that's maybe something that should be, you know, your own relationship should be you know, you shouldn't have to have a permission slip signed to go have a procedure done. Where a man can go have a vasectomy without anyone's permission, because, oh, you know, it's reversible. Another concern, which I think I just lost my train of thought a little bit. Yep, no, it's gone.
That's a thing that's going on now, that women have to get consent from the husband.
If you would like to have tubal ligation, yes, you need to have consent from your husband. And
if a guy wants a vasectomy, they don't need our permission.
Correct. Oh, this was my backup point. Oh shit, I lost it again. Oh, and if you were an unmarried female and you would like a tubal ligation because you have decided that there is no way in hell that you are going to have a child, and you have to actually have a psych eval in order to get a medical procedure.
No,
that is unbelievable.
That's crazy.
Welcome to 2020.
Yeah, so no.
Also, I'd just like to put in, if you have no uterus, you have no opinion on women's health. Thank you. That's all.
Unless you're supporting.
So note to self: you do not live in an advanced society or culture.
You think you do. Yes, we're still getting there, and the United States is also kind of a few decades behind a lot of other advanced or industrialized countries. in regards to women's health and accessing the care that one needs. For example, and we talked about this in the GYN, it takes an average of 7 years for a woman to be diagnosed with endometriosis. And then she will be labeled as a chronic pain medication seeker when she goes to the ER because she's in extreme pain, regardless of the fact that she has, endometrial cells growing in other parts of her body that they don't belong, essentially giving her menstrual cramps in her upper abdomen or her chest, or PID symptoms because now her intestines are adhered to each other. There's some issues in this country that need to be fixed, and I feel like we might have just been set back a few generations because of RBG's death, but that's another conversation for another day. Thank you for coming to my TED Talk.
And you're not married, you have to get a psych eval?
Yep.
What if you have a kid out of wedlock and then you want to get your tubes tied after that? You
still have to get a psych eval because what happens if you are now going to be in a future relationship where you wanted to have children?
That is so crazy.
Question. That's if you're not married, you have to get that done.
If you're not, even if you are married, I do believe they still subject you to a psych eval. Okay. But then you also have to get your husband's permission if you're married.
Got it.
So make sure you get your permission slip signed. Yeah.
8th grade 4G mommy and daddy signature come in handy.
Could you imagine? I can't even imagine. And now go back a little bit, right? So think about it, because we're still here in this part of the world, in this country. Who is providing health insurance in most relationships?
The husband.
The husband, right? So if you go and use your health insurance to go have a tubal ligation without his permission, he's still going to know, despite the fact that it's your private health information. Despite the fact that you might be in an abusive relationship.
So if I can throw one other thought here, because we're on the nub of it. If you guys don't understand the concept of this conversation, healthcare, especially post-COVID, is one of the most giant repositories of power. Okay, and if you think of who the individuals are who hold that power, a lot of them are men, but it is very male-centric, and there's a lot of psychology behind it about, professions that have psychopaths and so forth. So, a lot of doctors are great caregivers, but then you run into the ones who understand the power that they have, and then you have administrators and so forth. But look around you in the world we live in, it's healthcare now that's running the show. So,
and remember where your place in healthcare is that you are now giving people one of their only times where they're going to have more than 15 minutes with one-on-one time with a healthcare professional.
You have power.
You have extreme power, right? Because now you can go in to the ER and tell that triage nurse, this patient needs this. I can't tell you the number of times I've gone in and said, this patient cannot go back to their home. Either it's not safe, or they're an elderly person who cannot take care of themselves, or an abusive situation, or the home as a whole was unsafe due to structural issues. You have a lot of power because you're seeing where this patient is coming from, because you can still have a well-dressed, well-put-together individual who is living in squalor because of psych issues, because of poverty, because of any other number of issues that no one in a hospital or a doctor's office will ever see. So keep that in mind when you're taking care of patients, because you really do have power to potentially improve somebody's life.
And with power comes great responsibility.
Yes, Peter Parker.
Yes, Uncle Ben.
All right. So now that we've had that really delightful conversation, which I think is probably almost more important than prolactin, oxytocin we're going to talk about real quick. So oxytocin is produced in the pituitary gland, and this is what stimulates labor. It also is the quote-unquote bonding hormone, okay? So this is why when women give birth, they want to hold their baby. They're bonding with it because of oxytocin. Fun fact, oxytocin and antidiuretic hormone are very chemically similar. So if you have a woman who's going into preterm labor, it's a possibility that she's actually very dehydrated. Okay, so think about it, right? You're dehydrated. So your body starts to produce antidiuretic hormone. And because it's like, oh, let's hold on to all the fluid we have. We don't want to go pee it out. So as that surge of antidiuretic hormone starts to hit the bloodstream, the brain and the uterus are like, wait. Is this oxytocin? Is it time? It's time! Quick! Contract the uterus, right? And it starts to give her contractions. So you can actually you have a potential ability to slow preterm labor by hydrating a patient, by hydrating a woman. Kind of cool quirk of the body that you just stay hydrated, okay? Stay hydrated. I know peeing is challenging if you're pregnant because you have a Christmas ham sitting on your bladder, but this is just a nice little visualization of that capillary bed between the placenta and the uterine wall. Go ahead.
Do we carry a drug that slows down labor
No.
on the ambulance?
No, we don't. No. The only thing, honestly, the only thing would be fluids.
Fluids?
Yeah.
I'm only trying to remember. I was on a call with the medics and the lady was going into labor, but it was a far distance. And he drew up something, but like at the time I wasn't even in medic school and I particularly wasn't interested. And I was like, and now later I'm like, what did he draw up that he was saying to the other medic, like, oh, just in case, because she might have at the point she was dilated like 8 centimeters, but I just can't think about it.
When I was reading the textbook, they had a couple of ones that slow labor, but I don't know if like they're in New York Remac.
Probably not. I will say
this was in Long Island, so maybe things are different, right?
Yeah,
it's very similar. The pharmacopoeia is very similar. I will say it might have been MAG. But again, that's not in protocol as far as I'm aware for Nassau Suffolk, or I don't know how long ago this was.
Well, then they didn't do it. Then I didn't see anything.
Exactly. They didn't give him anything.
Nicole, I had talked to a medic, but this may have been a preeclamptic situation.
That's also what I was thinking.
Where magnesium sulfate in a bag was used, but I think that was the protocol.
Yeah.
Nicole?
Yes.
All right. I just want to let you know, I got an email from Scott that the students have to go to Mather today. So the 4 students that received that information have to go to Mather today at 3 p.m. for the orientation.
Okay.
So they will need to be there.
Okay.
All righty?
All righty.
Thank you.
No problem. Y'all got that? Don't be late.
Yes.
Okay. But yeah, so MAG also has a muscular relaxant to it. This is why we use it for torsade de poids, or one of the reasons we use it for torsades, because it has a relaxing kind of, it sort of counters calcium, right? So if you think about, now you have the uterus, which is extremely muscular, contracting, that's using a lot of calcium to make that muscular contraction, so that MAG might slow it down and ease it up a little bit. But again, unless they were using it kind of in the pre-eclamptic protocol, that is not currently applicable for slowing childbirth. Great question, though.
So how would MAG kind of help with a pregnant woman stopping from seizing?
So
I read that too in the textbook, that they kind of use MAG to kind of stop a pregnant woman from seizing.
Yes. So they don't know how it works 100%. The thought is that a pregnant woman is eclampsia, preeclampsia, eclampsia, because right, that dividing line between preeclampsia and eclampsia is the seizure. The thought is that MAG, the female patient is extremely hypomagnesium, has extremely low magnesium. So by giving the patient magnesium, it's going to stop the seizure because they think that that's what's causing the seizure. It's again, you're talking about women's health issue where they don't really know why. Just like they don't know why labor starts. There's no like reason that all of a sudden, one day she's like, "Oh, we're giving birth today." Like they haven't found out why. I don't know if it's because they haven't studied it or because they haven't determined what it is, but yeah.
Do you think it's kind of like they determine like your body just kind of like it's almost like an action potential, right? Like so you reach like this certain point where everything's just right, the hormones are just right, everything is just kind of just right, and your body's like, all right, let's do it.
Yes, I do think it's that to a certain extent. I think but then that doesn't account for like preterm labor, when the baby's not fully cooked. I think that works in like when it's, 40 weeks gestation, baby's proper weight, baby's fully developed, ready to go. I think that when there's preterm labor, there's some like weird variation of the hormones where it's like, we're gonna do it. The baby's like, excuse me, I'm not cooked yet. And we don't know why, which is kind of just wild. It's 2020. We have no idea why labor starts. So, fetal circulation. Fetal circulation is a really kind of curious little thing because it bypasses the lungs for the most part, okay? Think about it. You're kind of floating in this fluid pod. You don't need lungs. You're not breathing oxygen yet. So in order to accommodate for this and the fact that you're now getting all of your blood through your belly button, there's a number of different shunts that directs blood away from your immature organs so that they have a time to kind of develop in safety, because that's a lot of pressure, right? So you have the ductus venosus, I have such a hard time with this word, the foramen ovale, and the ductus arteriosus. Okay, so let's talk about the ductus venosus, right? It's over here in the liver. So rather than the blood actually going through the liver to be filtered, because if you think about it, it's partially filtered already because mom's liver is doing all the work. It kind of bypasses up and around. Right here, so we're starting from the belly button, we're going up and around, and then kind of popping right back up to go to the heart, right? So then the blood goes to the heart, and then you have the foramen ovale, which I just have such a hard time saying, which is the hole, or what we like to call the hole between the heart, right? So you have this spot right here where you have blood mixing, right? Because traditionally in an adult heart, you have oxygenated blood on the left side, this side, and you have deoxygenated blood on this side. Okay? Right now you have this opening, right? So the blood comes in from the liver, and it's high oxygen, right? Because mom's doing a good job of giving you oxygen, right? Comes and pops up, and all of a sudden this is where the blood starts to mix, okay? Because now you have blood coming back from the rest of the body, right? From the vena cava, you have deoxygenated blood, and then you have this high oxygenated blood coming in here, and it just becomes a blood party. And then you have up here the ductus arteriosus, okay? And this helps bypass the blood flow to the lungs, okay? So the lungs are not they're getting some oxygen, but not the amount that otherwise as a adult out in the regular old atmosphere you would get. So, fun facts, because this also kind of plays into why we have issues as adults. So after you're born, right, the pressure change from being smushed out of a vagina, okay, is supposed to close the foramen ovale, and then it also changes the ductus arteriosus. It starts to now bypass the ductus arteriosus as well as the ductus venosus. Okay, so these figures, or these this vasculature here collapses. Okay, because now once that baby takes its first breath, this closes, the circulation now has to go the correct way, right? Because again, that pressure of the vagina wrapped around a baby's chest is kind of what stimulates that first breath and changes the way that the circulation happens. This is also why you might have babies who have the acrocyanosis, right? Remember back in neonates and babies when they have, or in the future when we go there, how they have like maybe like blue or dusky limbs? That's because that fetal circulation is changing, right? It maybe hasn't 100% gone through yet. And that's fine, right? Because they're little and they can compensate pretty well. But if these don't close 100%, then they end up needing surgery, right? Because they have all sorts of problems with what are we doing here? With circulation.
Is this kind of where like a murmur would come in? Like say if like if the foramen ovale didn't completely close, or if one of the other things, could you then develop some sort of murmur, or is a murmur completely different in its development?
So a murmur,
kind of like a congenital.
A murmur is a little different, and it is mostly congenital. But basically, the murmur is when these valves, like the existing valves, aren't closing properly. When you have, this is a when the ductus arteriosus or the ductus venous or the foramen ovale don't close, you have a more severe blood mixing problem, specifically if they still have a patent foramen ovale, because now you have a hole, literally a hole in the heart between the right side and the left side. So instead of sending purely oxygenated blood around the body, you're sending like this kind of mixed dirty blood that isn't well oxygenated. So it's kind of living like almost like hypoxic, right? You're living at this like kind of under oxygenated state because the blood is mixing. Your lungs are working fine, your heart is working okay, but that hole in between is creating issues.
Gotcha.
Okay.
Okay. Thank you.
No problem. So another fun fact is when the ductus venosus and the ductus arteriosus do fully close, they actually get turned into tendons, which I think is on the next slide. Maybe. Work. Yes, or sorry, they become ligaments. So when they become ligaments, I'm going to go back to a slide just so you can see. So the ductus arteriosus becomes the main ligament that the heart is suspended in the chest with, like combined. So the ductus arteriosus and the aorta are the two things that hold your heart kind of where it sits in your chest. So when you think about a patient who's experienced trauma, right, especially like that sudden stopping of a car accident, right, that high G forces just being applied to those organs, that organ, the heart, is just swinging, okay, because it is the seat of a swing attached by the ductus arteriosus and the aorta. So as it swings, those forces can shear the aorta. The other problem is the ductus arteriosus is a very kind of thick ligament, right? It's very fibrous. So that also can cause sheathing forces to the aorta, and kind of like sort of like when you're using a cheese cutter, right? It sort of does that kind of same vibe. And that also happens with the ductus venosus, because now that becomes this fibrous tissue in the liver, and as the liver moves because of G forces, it kind of just serves as a knife right through the liver, which again, super vascular, not exactly something you want to slice and dice. So yes, those things, part of your fetal circulation, start to create issues in trauma patients as adults. I don't know where this little arrow came from. Let me get rid of it for you guys. So a little bit more, another picture of how fetal circulation works. Where's my eraser? Okay. So we talk about how premature babies have a lot better chance of survival now than they did, in, as I like to always say, 1600s France. but there's still a high risk for a lot of these babies. Premature is before 25 weeks and or under 5 pounds. Okay, those two kind of are the two roles or the two points that you need to remember when it comes to how what a preterm baby is. I know medics who have delivered babies at 22 weeks or so, and their airway hasn't opened yet. Okay, and there's just like skin across their nasal passages and their mouth. So there's no way that even if they were to provide the baby with compressions, that it was going to survive, because there's no way to get it oxygen other than through the placenta. And if the placenta is no longer attached to the uterus, there's no oxygenation. So this is also one of those things where you need to be very empathetic and cautious when you're dealing with a mother, because it's very traumatic.
Would you have to at that point would you just be doing compressions or not? I mean,
yeah,
I don't know how big a 22-week-old baby is.
Probably would fit in your hand.
Yeah, like probably about like this big. Like, would you even be doing
that comes down to, are you giving mom psychological first aid or not?
Right.
So it's a possibility that you'll be doing compressions. You'll know it's futile, but you're really giving her the idea that you've done everything that you can for the baby, that you didn't just like write it off as futile.
Okay. Could you go back a slide? Sorry.
Yeah.
So it's at 22 weeks or less that if they have like a sudden miscarriage, that you just wouldn't really try anymore.
Again, it's going to depend on what the presentation is of the child. Like if they do have a patent airway, and they're trying to survive, yeah, you're still gonna try one way or the other. But I guess in the back of your head, for your own psychological health, do understand that there's nothing that you can do. Like if the baby passes, it's not your fault. It's just too young.
Yeah, I had a one of my coworkers. I was in the ER. They came in with the lady. She was crying, and she had the biohazard bag with the suction canister. And I was like, man, what's going on? What happened? I was like, oh, she had a miscarriage. And but I remember she said it was definitely less than 21 weeks. And she said that it came out smoothly, and it was still moving. The heart was still beating, but there was nothing you can do. And I was like, man, like, did you try? Like, no, it's there's no point.
Yeah. And again, under 21 weeks, the baby's not developed enough to survive.
Yeah, I had a 5-month miscarriage, and it was just skin. There's nothing you could have done.
Yeah. It's and like anything less than like 15 weeks or so, it honestly doesn't really, it can look mostly just like tissue, because a lot of the features are more on the microscopic side. So it just will look like a mass of tissue. The younger it is. And yeah, like it's going to be small. It's going to be an easy, quote unquote, easy labor in terms of pain. But when it comes to emotional and psychologically, like that's really tough for everybody involved. I mean, as EMS providers, we do tend to compartmentalize very well, but it doesn't mean that it's not something that could affect you. And that's okay. You're allowed to have emotions, we promise. Brianna, we good?
Yeah, thank you.
No problem. So when we, as medical professionals, are talking about a woman and her pregnancy history, we use GPA, or gravida para abortion, in order to, I know this is a little stated a little different, in order to dictate or to document what her pregnancy is. And I like GPA because it's school related and we can kind of remember it, right? So as you look at here, gravida is how many pregnancies she's had. Para, the term is para, is how many have been born. and then you can break that down to, was it to full term or were they preterm? And then abortions. Go ahead.
I have a question about para.
Yes.
I was reading the book and I was reading like preterm or whatever, and then I read para and it says that's the number of pregnancies or deliveries.
Yes.
Does the child have to be living upon delivery for it to qualify? No. Okay.
No. It just has to have been born.
Okay, so if you have like a stillborn baby, then
yes. So for example, so you have a woman who is G2P2A1. She has had she's been pregnant twice. She's given birth twice, but one of those could have been a miscarriage, or one of those was a miscarriage. So you can also have a woman who is G1P2A0. She had twins. Okay. Or you'll see this, you'll see maybe G3P2A1. Maybe she had a miscarriage. Maybe she had an abortion. And we use the word abortion in, again, not like that you went to Planned Parenthood and had an abortion. It could have been a miscarriage. It could have been a stillborn. It could have been, most of the time it's a pregnancy loss before 20 weeks. Okay. And again, this is just like a basic breakdown for us in EMS. Like they do kind of break it down more specifically in the hospital. But if you're coming in and you have a woman who is in labor and they're like, okay, so what is this? Okay, so I have a woman who is, she's a 35-year-old woman, G3P2A0. They know what you mean. Okay. Like it just puts you and the L&D people on the same page, because if anyone has had any experience with L&D people in the emergency setting or in the EMS setting, they're rude. So it helps them understand, because they don't get what it is that we do.
So if we were to get a question on the test and it's like, oh, what does the P in GTPAL stand for? And the options are like between para and preterm, we would choose para.
Yes.
Okay.
Good. And again, if a woman has never delivered, she is a nullipara, which is just a fun word to say.
So, Ryan, if you can hear me, can you mute your microphone, please?
I'm sorry, that's my stupid dog chewing. My bad.
Hi, Jasper. So there are a significant number of body changes that a woman undergoes during pregnancy, beyond the whole like growing a big old belly and her boobs getting bigger. And now let's talk about them. So the uterus is, we talked about, extremely muscular, but it's also extremely elastic. It will triple in size and weight by 8 weeks. Okay. The uterus is very small, 70 grams without pregnancy, in the lack of a pregnancy. Okay, the regular old day. Things that are fun during abdominal assessment: if you do have a pregnant woman, at about 12 weeks, you will start to feel the gravid uterus above the pubic bone. Okay. 20 weeks pregnancy, you'll feel the top of the uterus at the navel level. 36, it's all the way up in her diaphragm. And then 40, at 40 weeks, the baby should be in a cephalic position, which is head down. And the baby should be positioned pretty much at the vaginal opening, at the cervix. So that's why the level of the uterus drops. And this is also one of those things that's kind of interesting in terms of when you're doing an assessment. If you have a patient who has been pregnant, maybe it's her like second or third pregnancy, right? She knows, you'd be like, do you know if you dropped? Okay, right? Because she'll know. Like, she'll be all of a sudden she's holding, she's got her coffee on her stomach all the way up, up high, and then like right before she's about to like go into labor, that stomach just kind of drops a few inches, and she's like, it just starts to look different. The stomach looks different, and it's kind of one of those things you start to pick up the more pregnant women you see, that, you know, the levels change. Also, if you do have a woman who's about to go into labor, or ask her if they do, because they do check this at prenatal visits, is if the baby is in a cephalic position or not. And just because the baby was at a cephalic position the week before does not mean that the baby has stayed in that position, okay? For the most part, they do. They kind of get ready, like a cannonball diver, right? Like the guys who get shot out of a cannon. They stay head down and they're good to go, but there's some babies who maybe get a little colicky, who maybe mom had a spicy meal and the baby moves a little bit, so they might be a back presentation, or they might have turned around completely and now they're foot presentation. So, make sure that you ask, okay? And there's sometimes when you can kind of see the baby moving also, where like you can probably get a good idea what position they're in. So based on the fact that you're carrying 8 pounds of Christmas ham on your bladder, and the fact that you're also carrying probably 20 to 30 pounds of extra weight just in your midsection, the poor bladder does take a beating. There's also a 50% increase in a woman's circulating blood volume when she is pregnant. So your kidneys are working 50% more than they usually are, which means that you're now producing more urine. There's a high risk of UTIs due to this, not only the smooth muscle relaxation brought to you by the hormone relaxin, which is one of the most amusing hormones that you can think of, because it literally does what it's called. It relaxes everything. But you're also kind of compressing the bladder, so there can be some stagnation of that urine motion. All the mammary glands in the breasts start to produce milk due to prolactin, that hormone, right? So I like how they call it inactive breast, like it's just chilling there, like just not doing anything. In the early weeks of pregnancy, as those glands start to become more active, right? They start to produce milk. The breast will become more tender. And this is why women's breasts get larger during pregnancy, because they're doing what they're supposed to be actually doing, which is feed a baby. Nausea and vomiting is, especially like if I use Kate Middleton as my example, right? She had hyperemesis of pregnancy, that really strong surge of hormones that kind of start around that time when that human chronotropic gonad hormone, the HCG, is detectable, is usually around the same time when all of those the vomiting happens. And some women usually will experience relief from the vomiting as they progress through their pregnancy, and there's some women who experience that hyperemesis throughout the entire thing. Those women, if they have hyperemesis throughout their entire pregnancy, there's a strong possibility that they're going to have significant dehydration, as well as a lower birth weight baby, because of the inability to keep the calories down, right? Because if you're constantly vomiting, it's hard to eat. All sorts of other indigestion and all sorts other things are common during pregnancy. There's a really fun midwife or wives tale kind of thing, that if you have a baby with a lot of hair, you will have really bad indigestion. Just fun little wives tales. As that gravid uterus starts to travel upward, it will create, and we talked about this during cardiology a little bit, right? We talked about how it will displace the heart. So let me get my little pen back, right? So as the gravid uterus starts to push upwards, that's a terrible arrow, right? It pushes the heart into this position, right? So we're going from kind of a normal swing to up here. Everything gets compressed. So women might feel short of breath because they have this, a gravid uterus pushing up against all of their internal organs. I saw a really funny meme where this lady's like, she got pregnant for the first time, and like she's like, well, where do my organs go? And she had like her intestines. She goes, I'll put them in a bag. So it can be extremely uncomfortable. You will see some EKG changes, specifically a left axis deviation, right? Because as your heart's vector, let me erase really quick. As the vector of your heart gets altered because of the heart's motion, right? So now, right, we talk about the way that the electricity of the heart moves from your SA node down. Hold on, let me just make sure I'm using the right. All right, we're in the not pregnant heart, right? Down and up in the not pregnant heart, which is the dotted one, right? So the main axis is this direction. But once you're in a pregnant heart, your SA node's here, but your axis is over here. Okay, so you're going to see that left axis deviation as the heart gets pushed upwards. There is a possibility that there's going to be some SVT that you might see in a pregnant woman. Again, her heart rate's also going to elevate because now she's moving 50% more blood around the body. Cardiac output is also increased, right? This is also part of the reason that women's feet start to blow up as you get more pregnant, because you're also compressing like the vena cava and you've got 50% more blood volume. So where does that extra blood go? Just like in CHF, it comes back from whence it came, and gravity's a bitch, so it ends up in legs. And then women are just like, I had toes, they were cool. Women's heart rates will increase from 15 to 20 beats per minute. Okay, so if you're a woman who's chilling at 60, a heart rate of 80 is totally normal when you're pregnant, okay? But that also means, we talked about this in cardiology, that women's baseline heart rates tend to be a little higher. So if her baseline heart rate is 90, and then you have a woman who's chilling at 110, that might not be 100% like tachycardia, okay? That just might be the effects of pregnancy and extra blood in the body. There's a possibility for murmurs, and that might be something that her doctor will have told her, not necessarily something that you are going to be picking up on your assessment. And they're talking about circulation, right? So that compressive factor, you have an 8-pound Christmas ham plus another 12 pounds worth of amniotic fluid and excessively sized uterus, kind of chilling in a bad spot. So if you, as a pregnant woman, are laying flat, you have the potentiality, especially as you're further along in gestation, to compress that the vena cava, which means that you're not going to have blood return from the lower extremities, which is going to then tank your blood pressure, okay? It tends to be an issue. Blood pressure will start to go down during the second trimester because now you have an increased amount of relaxin, and that relaxin is, again, relaxes everything, including the peripheral vasculature. We don't want to transport pregnant women on their back because it is potentially very dangerous, right? So that left recumbent or sitting up is much better in terms of transportation. Leukocytes count increases because of, you're kind of trying, not only is the body trying to keep the baby safe, but, you have all these things going on. Your body's like, what is going on? You also have an increased production of fibrinogen, which increases the risk of DVT. So let's talk about women's health a little bit more. Serena Williams, she gave birth 3 years ago now, and it's pretty common knowledge that you are at an increased risk of DVT as a pregnant woman. Even if you are active, you still have that stagnation of blood. You have extra blood circulating in your system. Now you have extra fibrinogen. It's just a possibility. So you also have the possibility of throwing a PE, a regular old PE, due to amniotic fluid that can get into your bloodstream during birth. It's relatively traumatic, okay? So there's some level of trauma, so there's a possibility. So as a woman, when you say, hey, I can't breathe while you're in a hospital right after giving birth, you would hope and pray that someone might take you seriously. So Serena Williams, a woman who has a previously documented history of having a PE, was sitting there postpartum saying, hey, I can't breathe. And they kind of patted her on the head and said, there, child, don't you worry, you're fine, you rest, you just gave birth. But lo and behold, she had a PE. So, it's a part of women needing to advocate for themselves, going, no, listen, doc, it's great that you went to medical school, but I know what I'm experiencing. Just something to keep in mind, okay? And that postpartum stage can last for weeks after birth because the hormones are still in flux. So this is why you have women who can still have eclamptic seizures like 6 weeks after birth. This is why you have women who can still throw a PE a few weeks after birth. So this is why it's important that you get a good history when you are assessing a patient. Much like everything else, your tidal volume is going to be decreased because you're sticking that big old baby up in that joint. It changes the aspect of the chest excursion because it makes your chest a little more round, just because things need to be displaced. Where else are you going to put your intestines except in your chest? Fun side story. Oh, let me stop share for a second. God damn it. Okay. I have a friend who's an L&D nurse. They had this woman who had been complaining of being short of breath her entire pregnancy. First pregnancy. No, it's fine, it's normal. You're supposed to be a little short of breath. You're growing a baby. What did you expect? You're going to have a little bit of a hard time breathing. So she gave birth and started having even more difficulty breathing. They did a chest x-ray, and the majority of her intestines were in her chest cavity. Her lung was, rather than being from here to here, was just up here. And everything else was full of intestines. Because when you don't care to do an assessment on your patient, including taking lung sounds when they're complaining of being short of breath, you miss the fact that there are stomach sounds in a chest. Moral of the story, actually assess your patient. And any of you ladies who have not had kids yet, welcome to Nicole's 2-hour lecture of how pregnancy is terrifying. My poor husband. He wants kids so bad. Anyway, it's totally normal for a woman to gain about approximately 30 pounds during pregnancy, and this is kind of understanding that you are at a typical weight for your height. So obese women may not see an actual increase or in their weight during pregnancy. It's just kind of a transference of weight. Babies demand iron and calcium. One of the other essential items is vitamin B1, folic acid. Okay, folic acid is essential in preventing neural tube defects. Okay, and a good question to ask is, hey, have you gotten any prenatal care during this pregnancy? Because you'd be surprised how many women don't. Is that a question I heard or no? Okay. Good questions to ask. LMP, right? When was your last period? EDC, expected date of confinement. Because if pregnancy didn't sound more like jail, it cracks me up. EDC. So, right, that's their anticipated date of delivery. How long is their gestation? How many pregnancies, how many live births? Have you had any previous C-sections? One of the things that's really popular now in OBGYN, or I guess is called a VBAC. It's a vaginal birth after cesarean.
Did you restart the recording?
What's that?
Did you restart the
do you
recording?
need, am I screen sharing or no?
Yep.
Yes.
Yep, no, we're good. I'm recording. Good? Alright. So, a VBAC is a vaginal birth after cesarean. These patients, there's what they believe to be an increased risk. So, here's your uterus. When they do a C-section, usually they cut the skin this way, and they cut the uterus this way. Sometimes they go this way. The problem is when you cut a muscle, it does not heal 100%. So now you're expecting this muscle that has a weakness in it to push an 8-pound Christmas ham out of, a small space. So there's a possibility of uterine rupture along this, suture line, okay? So if you have a woman who is a VBAC, you might have to just kind of be a little more cautious. there's plenty of women who do not experience pain. Or they'll experience what's just called back labor. So they'll just have lower back pain. It's kind of a little like annoying. And they're like, yeah, no, like I just having this back pain. And you're like, okay, you're probably in labor. Has there been any vaginal discharge? Is it bleeding? Has there been a mucus plug or a rupture of the membranes? Some women don't notice necessarily that they've had a rupture of the membranes because they think they may have urinated themselves. Or they went to the bathroom and there was a little more urine than expected, right? The toilet timing is always a little, whatchamacallit. Have there been any complications, right? So does mom know, does mom have hypertension? Does mom have gestational diabetes? Does mom know of any complications with the baby? Okay, when the babies that I delivered had a known heart defect and they asked to go from Howard Beach to NYU in Manhattan, or Hospital 1 for those of y'all who work the city. And yeah, that didn't happen. But she knew, like, this baby's going to need heart surgery. Okay, cool. The urge to bear down or move bowels. Or as I like to say, ma'am, please don't push. Other various complications, because it's just so much fun to be pregnant. Antepartum issues, right? We talked about hyperemesis gravidarum, right? Is severe nausea and vomiting, morning sickness, really bad morning sickness. Most of these women will be taking Zofran to kind of manage if they've seen a doctor already. RH nope, it's not happening, right? So if you know what blood type you are, like for example, I am O positive, which means I am RH positive. If you are an RH positive in an RH negative mother, the body will try to get rid of the baby because it doesn't recognize it, okay? So it becomes like an autoimmune issue. Most of the time, it's the second pregnancy that triggers, like, right, remember we talked about allergic reactions where you have to have a trigger, sensitization, there we go, came out, sensitization, and then you can have a actual reaction. So that first pregnancy might be okay, but it tells the body, hey, this RH positive thing, we can't do this again. And then the next pregnancy, if it happens to be an RH positive baby, the body will destroy it. So a lot of women will have miscarriages because of this, okay, and not really realize it until, they go to the doctor and the doctor's like, we figured it out. In the event that is a thing, they usually give the woman immunosuppressants to make it through the pregnancy. Gestational hypertension is a new onset of a high blood pressure, and gestational hypertension has a possibility of moving into what's called preeclampsia. Okay, preeclampsia is a multifaceted syndrome. Okay, not only does it have hypertension, but there's protein in the urine. There's thrombocytopenia, right? Not enough platelets. The liver function is overall impaired, so you'll have liver enzymes that are elevated and all sorts of other issues. The kidneys are not working properly, can result in pulmonary edema, visual and cerebral disturbances, right? So you might have auras or bad headaches or other issues to that effect. The problem is that preeclampsia opens the door to actual eclampsia, which we'll talk about in a little bit. Another sort of like paralleled issue to preeclampsia is what's called HELP syndrome. It's considered a variant of preeclampsia, but it's possible to have HELP without the high blood pressure. Okay, so that kind of was that delineating factor between preeclampsia and HELP. Same sort of symptoms where the patient has very low platelet counts, which means that they're going to be bleeding, elevated liver enzymes. There might not be protein in the urine. Most of the time, and if you look at your protocols, which I highly recommend you go look at your preeclampsia protocols, some of the signs where you can call to get magnesium for the patient is upper right quadrant or epigastric pain, visual disturbances, very high blood pressure. Okay, so these are some of the things where you are anticipating that the patient will start seizing. Okay, just, you don't really need to know all of the specifics between the two. You just kind of need to know between HELP and preeclampsia, but you do need to understand that this is one of the risks associated with pregnancy. And if a woman has had preeclampsia with a previous pregnancy, there is an increased risk she will have it with the next. Okay. Things that they kind of associate with preeclampsia, which I think that the advanced maternal age is sort of, I think, a little bit falling out of kind of a classification because women are getting preeclampsia no matter what, and I think that's just an overall poor health going into pregnancy. But the progression can be very unpredictable. The delineating factor between preeclampsia and eclampsia are seizures. Okay? Until a woman goes and starts having seizures during pregnancy, she's preeclamptic. Okay? And the only way to treat eclampsia is to deliver the baby. Okay? We can treat them with some magnesium to stop the seizures because remember, if you are seizing, you are not oxygenating. And if you are not oxygenating as a pregnant woman, that means you are not oxygenating yourself and the baby. So it becomes more complicated. What else? Yeah, fun. Eclampsia, in shock and surprise, Black and Hispanic women are at an increased risk of developing preeclampsia and eclampsia. Thank you, healthcare system, for underserving people yet again. Usually it's about 20 weeks. It could be up to 4 weeks postpartum. There's been women who I've experienced who are having for new onset seizures 6-week postpartum, which is still kind of classified as eclampsia. Yep, I think that's it. That's it for that one. That's good. Gestational diabetes. Just like preeclampsia and eclampsia, if you have gestational diabetes for one pregnancy, you have an increased risk for the next pregnancy. And the cherry on top, if you have gestational diabetes, you are going to be more likely to develop type 2 diabetes later in life. It's thought that during pregnancy, the ability to metabolize carbohydrates and insulin deficiency is kind of skewed by the hormones of pregnancy. So it creates all sorts of issues. And on top of that, you're also going to end up with a very high birth weight baby because this kid's pretty much living in a magical candy land of sugar. Even just regular diabetics who are pregnant, like type 1 diabetics, are also at risk of having very high birth weight babies. Now also the problem is after that baby is born, there is a strong possibility that they will tank. Their blood sugar will tank. And you'll have this like very lethargic AMS newborn who needs resuscitation because their blood sugar has just plummeted because they're unable to moderate their body temperature, and therefore they burn the sugar, but because they've been exposed to so much sugar, their body overdoes it and it just goes and their BGL drops.
Nicole, is that also how juvenile diabetes, is that how it works also or no?
So juvenile diabetes is thought to be autoimmune. So if you have a mother who is a diabetic, it's a stronger possibility that the baby will be also. But there's some level of damage to the pancreas. Less, like usually those babies who are born to gestational diabetic mothers are able to kind of figure it out after a while because, you know, they have a fresh, new, clean pancreas and are now feeding, or quote unquote feeding themselves rather than being completely reliant on mom's blood. So they usually are able to kind of moderate it a little bit better. PE, we talked about that a little bit. Sometimes it's a blood clot, sometimes it's amniotic fluid. Increased risk of PE due to a C-section because you've literally just had your abdominal wall ripped open and there's clotting factors going on. And it increases your risk of pulmonary embolism pregnancy overall, like 5 to 6 times. Sounds delightful. Sometimes infections can be spread from the baby to the fetus during pregnancy. Most of the time, it's those really delightful sexually transmitted diseases that are transmitted, and a lot of the times it causes developmental delays and blindness and other issues. Sort of like, remember when Zika was a thing? And a bunch of women were giving birth to babies with little teeny tiny heads with microcephaly. Sort of the same concept, but maybe less tiny Oompa Loompa heads. Torch infections, again, similar, just kind of the torch is a toxoplasmosis, other, because why would we not use H and S and rubella, cytomegalovirus, or herpes simplex. Okay, herpes simplex, right? Herpes simplex is what gives you a cold sore. Herpes simplex kills babies. Okay, this is why because their immune system's just not developed enough to be able to fight off the infection. So this is one of those reasons where it's like, don't kiss somebody's baby if you have a cold sore, because you will kill them. Because they will just spread the infection, and it's just a disaster for them overall. Other things that you need to know in regards to antepartum disorders, which is before birth, before, abrupto placenta, which is when the placenta will tear away from the uterine wall. It's usually around 20 weeks gestation where there's a problem. There's sudden pain, and sometimes bleeding. Okay. So if you look like in the partial abruption right here, the very first image, see how the placenta has torn away from you have that like little pocket of blood? That can happen, and the woman will never experience bleeding because the blood just stays there. And that if it's a very small abruption, most of the time they put the woman on bed rest and call it a day, and they just wait for her to go into labor. If it's a large abruption, the problem is now not only is mom hemorrhaging into that space, but the baby isn't getting any oxygen or nutrients. So it becomes, more complicated and troublesome. When we talk about like a rigid uterus, right? Like that whole gravid belly will be hard to the touch. I don't know if anyone has palpated a pregnant lady's belly, but usually it's relatively soft, okay? Also, when we talk about a woman going into labor versus Braxton Hicks, we'll talk about what that should feel like as well. I think that's coming up really soon. So other than abruption, which is painful, you have placenta previa, which is not painful, but is characterized by bright red bleeding. Okay, so basically, rather than the placenta being implanted nice and high in the uterus, it's low, and as the baby starts to get larger, it starts to kind of smush the placenta, which kind of causes it to leak. Okay, if that placenta is fully across the vaginal opening, that baby will not be born appropriately, right? Because now the placenta will be born first, and that baby will be unable to breathe because they're still inside without their snorkel, essentially. So those are the babies who will need to be delivered by C-section. So this is something that's commonly picked up during ultrasound. This woman will know that she has placenta previa, hopefully, if she's been getting prenatal care. And this is someone who you would be bringing them to, hopefully, the hospital of their choice in the event of labor. We talked about uterine rupture already regarding VBACs. It also can happen spontaneously in an otherwise healthy uterus, because who isn't terrified now? Most of the time it's because of like a prolonged trauma or prolonged obstructed labor. So like if the baby's stuck, or direct trauma to the gravid uterus itself. So, a seatbelt injury or MVA or falling downstairs, right? Because now think about it too. Women who are pregnant, not only are their whole center of gravity completely skewed because now they're holding 20 to 30 pounds directly in front of their body, but they're also their body's producing relaxin, which not only does it relax all of the muscles of the vasculature, but it also relaxes tendons and ligaments, which is really helpful when you're trying to, when the vagina and the cervix dilates and allows the baby to pass through an otherwise small bony opening. But when you're walking around carrying 20 pounds of extra weight in front of you, there's a strong possibility that all those tendons and ligaments that hold things like your knees and your hips and your ankles kind of stable becomes a little bit more wiggly. And things like, tripping and falling or twisting an ankle becomes a lot more possible. In regards to uterine rupture, traditionally a woman will experience a sudden sharp tearing pain, signs of shock and a rigid abdomen. Labor will suddenly become less potent, right? So she might have been in labor for an extended period of time, and then has a sudden tearing pain, and all of a sudden, like, she doesn't feel like she has to push quite as much anymore, because she's lost that stimulus because the muscle is so damaged. Going back to, we talked about if a woman has the premature rupture of the membranes, right, and labor for more than 1 hour. Also, if it happens to be anything longer than that, right, so like maybe she's ruptured her membranes and they sent her home, like, go walk around a little bit, there's a possibility of increased infection of the baby. Things that annoy me. Many times, you'll see this in hospitals, is that a woman will go because she is in labor, and they'll check her in, and they'll check to see how dilated she is, and she'll be at 2 centimeters, and they send her home. I have seen it a number of times.
Yes, that happened to me with both my pregnancies. They wait until your contractions are literally a minute apart before they can actually admit you.
Yeah.
And it sucks because I actually had to go to the hospital about 7 or 8 times because I wasn't dilated enough or the contractions were too far apart.
And you didn't
So
flip
it
a
really
table?
sucks.
like I would have been that angry bitch, like flipping tables, like, no, I'm staying here. It's ridiculous because, again, labor does have a certain, like, progression to it, but you also can go from 2 centimeters to 8 centimeters in a pretty quick period of time. Or what happens if you never go past 2 centimeters and the baby's in distress? Like, just me, but like, I know women have been birthing babies for thousands of years, but we have this technology now to, like, monitor that. Shouldn't we care? Just my thoughts. Anywho.
I've seen them make mommies like walk the halls.
Mm-hmm.
Like, oh, you're having Braxton Hicks, just go walk the halls for like 10 minutes. And then back then when I used to go down to Lutheran a lot, like they used to, like, you just see like 5, 6 like pregnant mommies just walking down the hall.
Like racing around the hallway.
Yep.
Who's gonna give birth first? With their little IV poles. Yeah. We talked about this already a little bit. Spontaneous abortions. The before 20 weeks of gestation, the mother's body has, in one way, shape, or form, decided that this is not a viable fetus, and expels the child or the embryo. Crampy back pain, bleeding, usually within the first trimester. There's plenty of women who never even know that they're pregnant, and they just have what they believe to be a late period, right, with maybe some tissue involved. The problem with a spontaneous abortion is if it's in the later weeks of gestation, there may be some byproduct of fetal development that is left inside the uterus, which can create not only hemorrhagic concerns, like where you see here in the bottom left corner, the incomplete abortion, but it also can create an increased risk of infection for the mom. Other things, and if you really want to go down a nice little rabbit hole, look up stone babies. If a woman has a missed abortion, right, like her body aborts the baby and then, like, just doesn't expel it, she may never know it. Her body will potentially produce a period around the baby, and then the baby becomes calcified inside the body, and it's what becomes what's called like a stone baby or something. Have fun with that one. That was a good 20 to 30 minute rabbit hole I jumped down a few years ago.
There was some Indian lady that had that in India. She was like 80 years old and had the baby in her since she was like 40.
Yeah, And like they're like, we can take it out or we can just leave it. And you're like, oh Lord, okay.
I think she just kept it in.
Yeah.
Lithopedion.
There you go. Have fun. Enjoy. Godspeed. Good travels in that rabbit hole. Abortions. So if there is a spontaneous abortion, or we like to call a miscarriage, it could require some what's called a D&C, a dilation and curettage, which if you go to the ORs, you may see this. They literally take a kitchen spoon and scrape the inside of the uterus to remove any portions of the placenta that may still be inside. And yes, when I say a kitchen spoon, I mean it is a sterilized kitchen spoon. Again, one of those things you see on rotations where you're like, why? Intrapartum complications. There are 3 stages of labor. This is something you need to know. The first stage is the dilation of the cervix. The second stage is the emergence of the baby. And the third stage is when the placenta is expelled. Okay? This is very commonly a state test question. It pops up a lot. They want to know if you know the 3 states of parturition and or labor. So like you might be like, okay, so you are delivering a baby on scene and the baby has just been you've just delivered the baby and cut the umbilical cord. What stage of labor is your patient in? Third. Exactly. Perfect. Again, it's labor or parturition is it's a positive feedback loop. We talked about those earlier. That the uterus starts to have more and more contractions as it becomes irritable, right? Because it's hit whatever point that requires it to now be irritable and contract. Okay, Braxton Hicks. One of the easiest ways to determine between Braxton Hicks and regular labor is 1, the regularity, and 2, if the entire uterus is involved or not. So Braxton Hicks is sort of like the practice stage of the uterus right before labor actually occurs. Right? So the uterus is kind of, it's go to the gym. It's flexing. It's like, yeah, no, we got this. We worked out. But part of it will start to tighten while the rest of it's still like pliable. Okay, so if you do palpate a woman's abdomen while she says that she's having a contraction, if the whole abdomen is not rigid, it is more likely to be Braxton Hicks. Okay, just helps you kind of determine one way or the other if it's what's going on with your patient and how quickly you may need to drive to the hospital. As Ashley said, right, the hospitals won't take you until you have a movement or a contraction every minute or so. Usually the contractions will last for about a minute. May last longer, may be a little shorter, depending on the woman, depending on how many children she's had in the past. Crowning, right, that's the only time where in EMS you get to actually see a lady's vagina, is if you're checking for crowning. And mom will tell you, like, oh, I have to push, the baby's coming, like, for the most part, like, it gets to that level of urgency, right? That's what we consider an imminent delivery. If you do believe that an imminent delivery is happening, this is when you set up on scene, okay? This is not when you decide that it's a good time to take mom down 3 flights of stairs on a stair chair. If for some reason delivery does not proceed well, you got about 20 minutes before you go to the hospital, right? Because if you're sitting there, she's like, I have to push, and then nothing's happening, and the baby's not moving forward, there's a strong possibility that the baby is in distress, and you'll go to somewhere where that has an OR. More things that annoy Nicole when it comes to women's health. I want you to look at the pictures on the left, and then look at the pictures on the right. What we traditionally use in American labor and delivery departments is what's called the lithotomy or supine position, where you take a woman, prop her legs over her head, and say push, and assume that a baby's going to pop out. other than the fact that you're literally fighting gravity, it doesn't really permit the recruitment of other muscles other than just the uterus, right? Just think about it. Like, you're pretty much taking the legs out of the picture by propping them up in the air. You are laying in a position where you're not going to be able to like get the abdominal walls to participate. It's just uterus. Depending on where one delivers, they may provide you the option of this is, and Danny said, right, they got those ladies walking around because, oh wait, what happens? Gravity happens, and it helps the baby go down the birth canal. Some hospitals are a little more liberal when it comes to allowing women to decide which position they would like to labor in. Again, women have been birthing children for thousands of years, and then some dude decided to lay them flat on their back and said, go ahead, try now. So, yeah, problems with that one. And you might end up on a home delivery. If you do end up on a home delivery where you maybe have a midwife or a doula who is assisting, don't tell them what to do. They are way more trained than you are. They are calling probably because the baby is in distress and the labor's not progressing, and your job is pretty much to load and go. Okay? But definitely talk to the doula, talk to the midwife, and find out what was going on during the home labor, because usually you'll find some random ass kiddie pool full of water. Find out what was going on and like why it's changed. Okay, though they will be some of the most valuable informants you will ever have when it comes to that situation. Sidebar, go ahead.
So Nicole, having been through this 4 times with my own children and also a couple of other times in the EMS field, obviously we have protocols, but let's say we're in a situation where the woman says, no, look, I've been doing this, I've been practicing, I want to do it this way, we're going to do it that way, right?
Pretty much.
Call medical control, say, look, she wants to give birth, sitting on a ball, etc., with her husband standing behind her, whatever it is.
You don't even have to call medical control.
Yeah,
as long as you don't have to transport. Okay, if it comes to the point where you might have to transport this woman, you are going to have to explain to her, listen, I know this was your birthing plan,
right,
but something's not going the right way. We are going to need to, change the plan a little bit, and you're going to have to make sure that she is safe while you transport her. Yeah.
And just as an aside, I guess as a follow-up, I mean, have you ever run into a situation where, let's say, a woman had planned to do a midwife birth, and you get there, and the midwife, they call just for fun, and you get there, and the midwife's there, and I don't know what that protocol would be, and then
No. So basically, if there's a midwife on scene, one, there are much a higher level of training than we are.
Right.
2, they do those women do not sorry, asterisk women, but there can be male midwives. Those professional, they do not panic. I have heard stories of midwives. There's a procedure that they can actually take externally, take the baby and twist it in the uterus so it is in a cephalic position. They're stone cold. Like, we are delivering this baby. Like, in my head, they're all German. But they if they're calling, it's not like for funsies. It's because something is seriously wrong. Like this is their jurisdiction.
Right. Okay.
Yeah.
So final then, are we ever going to run into a situation where we deliver the baby and the mom says, I don't really, everything turned out great. You guys did a great job. I'd like to do an RMA. We're going to all stay at home.
It's a possibility. And I think that they have the ability to do so legally. I'm not sure. I know that they do have to go and file paperwork and everything, but in order to get the birth certificate, et cetera, like, and if there's a midwife on scene, like, they usually handle that. And personally, I would call medical control. Like, they called because there was a small glitch, but by the time we got there, like, the baby was born, and like, they don't want to go, and the midwife's here and they're willing to RMA. That would probably be okay, but I don't know if they're calling EMS, you might have like someone going, yeah, no, you have to go to the hospital. The midwife will probably, or the doula would probably be on the same page as you guys. Like, no, we really got to go.
So why I'm in this, why we're in this area, I have one other question. So in the reading, we came across some other circumstances that the book said this is not what you would do. However, you should be aware of these are things like when the shoulder is caught on the pubic bone,
Oh yeah.
or you have some sort of obstruction going on where the baby can't come out, and so just briefly on that topic, I mean, where do we go with that? Obviously, if we're not trained and it's out of scope, but let's say we did 10 rotations and everyone was like a shoulder obstruction and we're pretty good at it and we call medical control, we have difficulty with transport. What's the situation there?
So the primary I guess response to that is you would have the woman elevate her hips to try to prevent future movement. There are some maneuvers that you can do to kind of help, and like it's in the textbook, you actually can help kind of twist the baby a little bit so that the shoulder might be unstuck, which might be something that you're like sitting on scene, like Googling, like, oh shit, I know there's a thing. Hold on, don't push. So you might have the possibility of actually delivering that, but honestly, your best option is to transport. And I think if there's a shoulder issue like that, you're probably not going to have a lot of complaints from mom.
Yeah, I mean, when I was listening to it, I'm like, man, I don't want to be in that situation. You're doing something like the midwife would have no problem doing, but I'm like,
yeah, good. Yeah, no, you're like, all right, we're going to the hospital. Let's go.
Yeah, let's go.
Everyone in the ambulance.
Yeah.
Oh, here we go. Look, baby issues. So for the most part, when babies are born, they come out face down because let's talk about drainage, right? Gravity's fantastic. They actually changed protocol that you do not necessarily suction the baby's mouth and nose anymore. If it's clear and there's no sign of whatchamacallit, starts with an M.
Meconium?
Thank you, meconium. Clearly I need another cup of coffee. If there's no sign of meconium, that you don't necessarily have to suction the baby's nose and mouth if they are in no distress. But babies are slippery, so please make sure that you get a good grip as they come. So for the most part, if you guide the baby's head like downwards, the anterior shoulder will pop out first, and then the rest of the baby will follow. Once you get that shoulder out, it's a quick little slip and slide. They come pretty quickly. You do want to check the neck to make sure that the cord is not wrapped around, because if it is, you may have to cut the cord prior to the delivery of the entire baby. Okay, and again, baby delivery is a BLS skill. This is more of a review. There's nothing really over and above that we're going to do for a easy delivery. We're going to talk about challenging deliveries in neonates.
I have a question.
Yes.
So in my BLS original, I was taught that if you deliver a baby and you go to cut the cord, that you should hold the child below the mother for like a minute to ensure that like their blood volume isn't lost at all.
Yeah, that's actually a really good point. Perfect.
Is that still a thing?
Yes, it's still a thing. So, a lot of providers are really anxious to clamp the cord right away. It's a good practice. I don't know if anyone's like the baby person who delivers a lot of babies. It's good practice. So one, yes, you definitely want to make sure that the baby is on the same level of mom or a little lower. I'd say the same level is probably safer, because throughout contraction, right, that there's still that exchange of blood between mom and the baby. Once the placenta is delivered, that exchange stops. If the cord is still pulsating, that means the baby's still getting their blood. Okay? Kind of think of it as like the placenta is kind of holding on to some of my blood for now, and when I get out, I'm going to take it back. Sort of like that. So if you can palpate and get a pulse from the umbilical cord. When the umbilical cord is no longer pulsating, that is a good time to clamp it, because that does mean that the baby has received their full volume of blood. Great point.
Okay, thank you.
You're welcome. Thank you.
So you're just going to be able to just feel it?
Yeah. It's just like if you took like a pulse in your wrist or something, it's pulse. It's pretty muscular. Yeah. That everybody's going to be like, let's go deliver a baby. I want to go feel an umbilical cord.
Can I also add, a lot of moms, they don't want you clamping the cord right away. There's like a theory that it's better to wait before clamping the cord. So that's like a new trend, because when I gave birth 2 years ago, that was like a question they asked me. They were like, "Do you want to wait to clamp the cord?" So always ask first.
Yeah, 100%. That's fantastic. Very good to note. Also, another kind of weird, cool thing. So pregnant women actually will develop a dark line from their belly button to like their pubic bone during pregnancy, which is thought to help babies crawl up towards a breast. Um, Babies, if actually like if you deliver and like kind of leave the baby will kind of start to do like a crawl, like a weird GI Joe crawl up to a breast, because they will start to feed. Like if babies weren't kind of creepy and alien-like as it was, little GI Joe guy. Also the waxy, starts with a V, velexum, something to that effect, is another aspect of a newborn's immune system, and it's absorbed into the skin over the course of a few hours to a day or so. But when you're in the hospital, they clean that off the baby right away because no one wants a weird, goopy looking, waxy baby, right? So they haven't done any real research on to like if leaving that on for like to naturally absorb into the skin helps or not, but they have confirmed it's like part of the immune system.
It's the vernix.
Vernix, that's it. Thank you. Totally having a blank on that one.
I don't understand that black line thing.
It's just like
a direction. It's like a directional path.
Yeah.
Like they see it.
Yeah.
Okay.
Like their little tiny baby eyes are like, milk's that way. All right, let's go.
What's that line called again?
Which way?
Happy Trail.
What?
What's that?
Happy Trail.
Damn it, Danny.
Yeah. No, seriously. I recall that being present. What's it called again? Do you know?
I don't know if it has a specific name. I just know it exists. It's a darkening of that line.
Talking about the line on the stomach?
Yeah.
Yeah.
I think it's linear. Something like
Linnaea. Yeah, maybe Linnaea. Linea.
All right, cool. We'll go with that. You seem like you know what you're talking about.
Sounds good.
All right.
There we go. 10 points to you for figuring it out. 10 points to Gryffindor.
Negra.
No, it's a linea nigra.
It's black line in Latin. It's linea negra.
There you go.
I'm not saying that.
That's all it is. Black line. Nothing fancy.
Nothing fancy. Just Latin. See, and we go back to the very beginning of class where we talked about the Latin and Greek roots of everything. Love it.
Still want my 10 points.
I'm still giving you 10 points. Calm down. So when you are evaluating a newborn, we use the APGAR scale. If anyone has forgotten, here is your reminder of what APGAR is, right? So we're looking at muscle tone, pulse, grimace, appearance, and respiration. So grimace is really easy. Or respiration is also, like they kind of go in together. When you introduce a baby to a brand new kind of chilly environment, because there's a very low chance that you're delivering in a 98.6 degree 100% humidity environment, the baby will cry, all right? And the baby will make this face like, what is this? I've only delivered one baby. I mean, technically it was two, but the first one was out when I got there because they were twins. And this baby was a foot presentation. It's these little foot sticking out of the vagina. I'm like, man, please don't push. She goes, I have to. And this baby's like full blown slid right out of her vagina. And I was like, ugh. And the baby went, and I was like, kid, I feel the same way. Same exact way. I'm also unhappy that you are here right now. It's cold. You're wrinkly. You look like a little old man. But his APGAR was good. The one thing that you are probably going to do a little bit where, like, you know, if it's a normal looking baby, is you want to make sure that you check the skin color, right? You're going to really be determining between if it's a pink baby or a pink baby with blue extremities. That acrocyanosis tends to clear up after a few minutes, but this is why we do it at 1 minute after birth and then 5 minutes after birth. And if it's a particularly long transport, you can do it again. It's always good to reassess the newborn. Here we go, talking about the umbilical cord again. Clamp it in 2 places, cut in between. If you are using a scalpel instead of scissors, please don't cut yourself. If it's bleeding, you can put another clamp on, okay? If it's bleeding from the placenta side, the placenta has been delivered, you don't have to clamp that. It's really the baby side. It's a big deal. Skin to skin is very important, right? And this is kind of goes back to weird G.I. Joe baby crawling up mom's stomach to get to a breast. It improves oxytocin because as the baby breastfeeds, it stimulates the release of oxytocin, which also helps mom bleed less because it starts to help that uterus clamp down. It also improves bonding between mother and baby. The placenta is usually about 20 minutes or so after the baby is born. If you happen to drop a placenta on the floor, make sure you pick it up promptly. Make sure you bring the placenta with you because the OBGYN will evaluate to make sure that all pieces of the placenta are accounted for, because if not, a D&C might be necessary in order to make sure that infection or ongoing hemorrhage is not an issue. We talked about this a little bit already, right? With a newborn's head's too large for the birth canal and how we've screwed up human evolution. So babies can get stuck. That's an emergency. We go to hospital. Various complications that you may experience, okay? And I actually had a friend whose baby was a face presentation. He was not progressing, okay? And because he was not, and the hospital was like, are you sure you don't want to push a little harder? She's like, no, he's not going anywhere. Like, something is seriously wrong. I need a C-section. And then they thought she was just lazy for not wanting to push. But, like, again, heaven forbid we listen to a woman who feels the fact that her baby's not descending. And the baby ended up actually needing physical therapy for his neck because the face presentation strained all of those muscles in his neck. A brow presentation, right? Because that chin should be tucked. Sort of like, think about like watching any Olympic diving sport. It should be chin tucked, arms in, right? Aerodynamic. Breech presentation is an issue too because now the widest part of the baby, the head, is not the first part out. And shoulder presentation, that kid don't want to come out. If you have a baby who's a shoulder presentation, that kid is comfy. He does not want to come out. You have to go and get him cut out. Here, you want to talk about a terrible procedure that a midwife will do that we will not do. I would not necessarily recommend this. So you crank the leg back and then punch down on the symphysis pubis in order to release the shoulder. I'm going to go with it. I'm good on that one. That just looks painful. Yeah. So other variations on breech presentation. Again, if you see a butt or you see a foot, you're going to elevate the mother's hips and you're going to bring her to the hospital and let someone who has way more college debt than you do. Another one, the Zavanelli maneuver. Right, we talked about that shoulder dystocia again, right? You can twist the baby to try to help move the shoulder through a little bit cleaner. Nope, okay. The Marceau maneuver is if the baby's head is stuck. Remember, like for BLS, the most important thing is to help ensure that the baby can be oxygenated, right? Because now the cord is being compressed, so they're not going to get oxygenation. So you might have to insert your fingers into the vagina to help create an air pocket, okay? Again, we aren't really trained on a lot of these, so really just kind of fall back to BLS a little bit and don't worry too much about those things. Cord presentation, right? Hold on one second. Hello. Hi, how are you? Oh, fantastic. I'm in the middle of a Zoom lecture, so I will see you when you get here. All right, bye. Okay. So if you have a cord presentation, you want to make sure that you keep the cord moist and wrap it up because you don't want to allow bacteria to get into the baby. If you have an issue where it comes to like you might actually need to cut the cord, you wanted to also kind of figure out where you are in terms of the hospital as well. That just looks painful. I'm sorry. We talked about these. Okay. premature births, right? So if it's a baby, if the baby is less than 37 weeks old and less than 5.5 pounds, they are considered premature. High possibility that they are going to be hypothermic. Also a possibility that they might be hypoglycemic. Okay. Oh, here, tocolytic agents used to inhibit labor include nitro, magnesium, salbutamol, and calcium channel blockers, and indomethacin. Of those, we carry 3, right? Because we have mag, we have nitro, and someone named the calcium channel blocker that we carry.
Cortisone.
Perfect. Multiple gestations, IVF, okay, right? Like IVF has significantly increased the number of multiple births that we see. Let's just talk about Octomom for a second. Oh my goodness. Most of the time, babies who are hang out with a friend while they're in the uterus tend to be lower birth weight, just because there's just not enough space for a full, like 2 8-pound babies. Often they are also premature. So just things that you need to take into consideration. Other fun things is the uterine inversion. And this goes back to talking about hemorrhage and all sorts of other issues. If you pull on the umbilical cord to try to get the placenta out, there's a possibility you're going to get the whole uterus. This is why we don't pull. Okay. Fundal massage, which we talk about using to try to prevent excessive hemorrhage, is also a potentially dangerous in action, right? We only want to use that if the woman is severely is hemorrhaging severely. So the problem is now, as the uterus turns inside out, the cervix starts to, constrict because it no longer needs to be dilated. But then it also acts as a restricting band, so the uterus starts to swell. And then as the uterus starts to swell, it causes more restriction, and then the blood flow is cut off. And then is a very strong possibility that she will end up needing a hysterectomy to survive. Postpartum issues. Postpartum hemorrhage, anything more than 500 milliliters of blood is a concern. Yes, there is a significant amount of blood and fluid that is lost during birth, but if it's pure blood, that needs to be dealt with. The 4 T's kind of associated with postpartum hemorrhage is loss of uterine tone.
So we don't do, sorry, so
Go
we
ahead.
don't do fundal massages.
We do in the event of severe hemorrhage.
Okay, because I was reading and it said that a fundal massage can cause uterine inversion.
Yes.
So, if you give a fundal massage, would you be shocked if, you got a uterus?
I don't know. I've never had to fundal massage.
Fair.
I'm really good never having to do a fundal massage. Apparently, it's also extremely painful because you need to exert a lot of pressure to actually reach the uterus. So it's like you're really getting in there to massage. The textbook, it looks like they're just going oh, you're okay. It's you're really a little elbow grease. I don't have a good answer for you for that one, honestly.
I got you.
Go to the hospital.
After I gave birth, the nurses were like, imagine when you go to the spa to get a massage and they're really on your back, just pushing. That's what it's like to get a fundal. It hurts a lot. They're very rough.
Yeah, see? Good, with never having to do that or experience that. That sounds horrible. Whew.
Okay. Got it.
The birth rates in my POC classes are very low. So retained placenta causes hemorrhage. We talked about that already. Rupture, we talked about that. And then coagulopathy, right? So we talked about patients who have HELLP syndrome, patients who are preeclamptic, etc., who have lower platelet counts could have excessive bleeding. There's the horrible, this is what a fundal massage is supposed to be. I'm good. Nah. Breastfeeding. Breastfeeding is your number one reduction of hemorrhage that we should just be using. It's just good. It's natural. You're not punching anybody in the uterus. There is a possibility that a woman who starts experiencing severe difficulty breathing after birth has had an amniotic fluid embolism. Okay, keep that in the back of your mind when you are assessing your patient, right? It's a strong possibility, especially status post a C-section, or if placenta previa or abruption is present. Just keep it in mind. Shortness of breath, it pretty much presents as a PE, okay? Postpartum depression is something that we also don't really talk about much because remember, this country doesn't believe in mental health. It's a myth. A lot of women have no previous history of depression, and then all of a sudden they are not able to bond with their baby. They are afraid of harming the baby or themselves or both. And it can last from 2 weeks to more after after postpartum or postpartum. It's under-recognized, under-diagnosed, and under-treated, frankly. So just keep that in mind. Generally, the baby is well protected in a trauma. Direct blows to the gravid uterus is an issue. Penetrating trauma can kill the baby. So keep that in mind if you have someone who's sustained a stab wound or a gunshot wound in that general vicinity. The biggest problem for the fetus is an interruption of blood flow. Okay, so if you have a traumatic abruption, that's going to be a significant issue, not only for the baby, but for mom as well. Remember, it's a very vascular location, and there's a lot of blood. Also, women do not necessarily, or pregnant women do not necessarily present as being shocky, okay, because they have extra blood flow flowing around, right? 30 to 50% more blood flowing around. They can compensate a lot longer, but that also means that they will crash a lot harder. Fetal distress can be determined or kind of discovered through evaluation of the fetal heart tones, which sometimes are hard to hear, but the baby's heart rate will start to slow. Decelerations are like one of those things when you're in the hospital that they will go right to a C-section. Okay, so if the umbilical cord is compressed, or there's other maternal hypotension or hypoxia or hypovolemia going on, the baby may go to decelerations and will potentially need to be delivered via C-section. Because remember, the baby isn't in the driver's seat. The mom is in the driver's seat, so they aren't able to compensate on their own. They just are along for the ride. Various things that can cause, we talked about, relaxin and all the issues it causes in terms of like loose hips and feet and stuff that can cause injury. Seat belts are troublesome. They have a lot of these different things that kind of adjust the seat belt appropriately. And we just talked about this, right? It's harder to determine if a pregnant woman is in hemorrhagic shock or not. So always have a high index of suspicion for a pregnant woman who is involved in some level of trauma. Okay. There is like that's called a shock index. Is a tool that you can probably download on your phone if you wanted to. I don't know how many pregnant women you know who are involved in trauma in your area or you work, but they give you a way to calculate whether or not it's a high possibility that she's in shock. Again, BLS, we kind of understand this. Do not transport them supine. If you do have to board and collar them, make sure you roll up something and tilt them off to the left side so that they're not lying on their vena cava. Go to a trauma center, it's always good. This is also, if there is a cardiac arrest during pregnancy, as you see our resident here, who's not wearing gloves, is pushing the gravid uterus off to the side in order to increase venous blood return. Okay, it's something that you may have to do. And going back to that ethics question we had of do you perform a C-section on a pregnant woman who is in cardiac arrest? This is something that also would need to be taken into consideration as you potentially transport her to the hospital for an emergency C-section. Okay, that you need to move the baby off of the venous return from the vena cava. Other considerations: aspiration pneumonitis, drug toxicity. you're probably not going to be dealing with epidural drug toxicity in the out of hospital setting, and eclampsia. All right, cool. So that was a long one. I'm going to pause the recording for a hot minute. All right, let's do this. Oh, Lord almighty. Okay, neonates. Hopefully, because, I mean, like, there's those people who are like, oh my god, I delivered a baby, I'm so sorry. Yeah, hopefully you never have to deliver a baby. Only about 10% of newborns require some assistance at birth to help begin breathing. And only about 1% require extensive resuscitation, which is great news because I think probably about 1% of people actually deliver 1% of babies out of hospital. Most of the time you get there and they're out already and they're chilling and mom's like, I just need you to wrap it like a potato, because that's probably the best part of ever having to deal with newborns is when you're in the ambulance and you get to wrap them in the silver thing and you're like, look, it's a baked potato. In the event that you do need to do this, pray to your whatever gods you believe in, and definitely be that person who checks the protocols before you get there, because you'll know what the call type is. Check the protocols. We do not use this protocol frequently enough, thank goodness, knock on wood, to really have it down cold. You will for the REMAC and for the rest of this class, but afterwards it kind of fades a little bit, and that's okay. A lot of the time, the people or the babies you're going to be resuscitating are preemies, and those who are low birth weight or have some level of a risk factor. Okay, right? So questions you want to ask, which you really should be asking anyway: when is the baby due? Did your amniotic, did your membranes rupture? Is the amniotic fluid clear? Right? Because meconium means the baby's in distress. That's just period. End of story. You need to know that knowledge. Meconium equals baby distress. How many babies are you supposed to be having? Because trust me, the only time I delivered a baby was those twins, and we walked in thinking it was going to be one baby, and grandma's running around going, who's delivering the second baby? And I'm like, what second baby? So yeah, make sure you know if it's a solo or if it has a friend. And what other risk factors might be an issue, right? Does mom use narcotics, right? Because if mom uses narcotics, the baby's gonna have issues too. Emilio, you're deafening me. So babies who are undercooked or overcooked are at risk. Okay, because if they're overcooked, they're probably going to get stuck. They're a little too big. If the baby's bigger than 8.8 pounds, okay, again, probably going to get stuck. Probably going to need some level of resuscitation because they might have been a prolonged labor. Issues with mom, multiple gestation. We talked about all of these things. Meconium. Meconium is probably the one thing you really need to look out for the most. Shoulder dystocia or abnormal presentations, okay, you should probably be boogieing to the hospital at that point so you won't have to resuscitate. Prolapse cord, again, you should be boogieing to the hospital. Let them resuscitate it. The L&D people do this for a living. Don't take that away from them. Let them do it. We talked about this a little bit already, right? So like at 22 weeks gestation is a very slim chance of that baby surviving well. But the older they get, the more likely they are. So babies who are more than 5 pounds are going to be okay. Anyone who's less than 3.7 pounds is considered a micro baby and is going to have some issues. Okay, and they might really require resuscitation. I just like this picture real quick. I just like to draw your attention here to multiple pregnancy where it looks like they're fighting in there. Just use your entertainment for the day. Respiratory depression and hypothermia are probably the two items that we can fix the most, right? So we can keep a baby warm and we can breathe for a baby. So those are things that we can fix. Blood sugar, also something that we can probably monitor. You're clearly not going to do a finger stick. You'll do what we call a heel stick, right? I think anyone who's had a kid has probably seen that, where they take the same exact thing and you whack them right in the heel. It hurts a little bit less for them. So when a baby is born, and we talked about most of this already, right? Gravity happens, the fluid is drained from their lungs as they take their first deep breath. And then the fetal circulation changes. So the foramen ovale closes. I have such a hard time with that. The ductus arteriosus and the ductus venus all start to close. So the circulatory pattern changes. The baby starts to kind of function on their own as a real person. And now they have to also maintain body temperature. If we remember from, other BLS, babies have not a lot of body fat. They have a really broad body surface area and not a lot of musculature, so they can't shiver. They can't keep themselves warm. This is why we have to keep them warm. So when we talk about why a baby taking its first breath does so much, it starts to release adrenaline into the bloodstream, which starts to activate sodium channels, which, that first gasp, right? That's adrenaline. And as the sodium channels start to activate, it moves all of the blood, the fluid inside the lungs around so that they have proper lung capacity, right? So that compression pushes the chest, starts to kind of stimulate the closure of fetal circulation, as well as pushing the fluid out of the body, the baby's airway. And then the first breath pushes everything else out into the interstitial spaces for reabsorption. We're not going to talk about this again, but I'll leave it up so that you can look at it later because we discussed this already. Happy baby? Not so happy baby. What's our first look on this baby? You think it's a healthy baby or no? Huh?
It's like,
so it's pink, nice and pink.
Like the skin looks, good skin coloration.
Good skin coloration. Maybe a little blue in the fingers, right? The fingers are a little pale as compared to, like, especially you can see right back when his hand's next to his cheek, kind of pale, right? So maybe this baby would be a 9 on the APGAR instead of a perfect 10. So it might take a little while for the ductus arteriosus and the foramen ovale to close, which means you might still have some blood mixing, which means you might have that acrocyanosis, but which will throw off the SpO2, right? Because it could take a little while for that SpO2 to start to elevate because of blood mixing. Totally normal. If you have a baby who's a few days old and they're still kind of blue, that's a problem. Extended hypoxemia, like in anybody else, can cause brain damage, right? And this is one of the main causes of cerebral palsy, is brain damage due to hypoxia during birth or in the right around the postpartum stage, right? So if you have a baby who is not having a progressed like a progressively improving APGAR score, you're going to have to resuscitate. Okay, there's a lot of issues that an under-oxygenated baby is going to have. A lot of premature babies, the lungs are one of the last things to develop. So those little tiny lungs are not going to be healthy if they're premature. So you also need to be very gentle when you are, breathing for a baby. So we just talked about this, right? Larger body surface area means that the baby's going to lose heat a lot faster. And these are things that we're going to talk about again in environmental. And I think we talked about these already in weapons of mass destruction, is temperature and how things like how temperature is lost, right? So it can be through evaporation, like when you're sweating, like because if you get a fresh new baby out of a vagina, they're going to be wet. Radiation, convection, right? If there's air moving around, this is why you might have to suck it up and keep your ambulance really warm. The easiest thing that we can do is to prevent heat loss through evaporation, right? We dry the baby off, we wrap them up nice and tight, wrap them in the foil like they look like a baked potato. Ta-da, baked potato, perhaps a burrito, a bayrito, if you will. babies are not necessarily really good at all of those compensatory mechanisms that we are as we get older. They don't have the storage for metabolic increases that we do, right? Because the glycogen storages are not going to be as robust as ours because they're not really eating yet, right? They just stole all that stuff from mom. They're waiting for their first meal. So if you don't keep them warm, they're going to become not only hypoxic and bradycardic, but acidotic as well, because that blood's not going to be able to move around effectively and then reduce or improve waste removal. There we go.
Can you go back for 2 seconds?
Go ahead.
Can you go back for 2 seconds?
Yeah.
I'm good. Thank
Okay, no problem. Sort of like how we have the golden hour in trauma, or the 10 minutes, the platinum 10, right? We have the golden minute when it comes to the care of a newborn. So they should be breathing well in the first 60 seconds of delivery or be receiving ventilation, right? So if you deliver a baby who does not have any significant respiratory drive that you note, then you need to start ventilating them, okay? You do not, in post haste, right? You don't wait around and hope that they're better. So, when you're initially evaluating a baby, right, the first things you really want to check is if the baby's breathing and crying. Do they have good muscular tone? And are they full term, right? If you have like a chunky monkey coming out at like 7 pounds, that's good. That's fantastic. You want a chunky boy. You don't want this little tiny skinny baby who isn't going to be able to keep themselves warm, who's going to potentially be hypoglycemic. But remember, wrap them up. Wrap them up like a potato. Definitely make sure that the baby stays with mom, right? Skin to skin contact is fantastic because mom is warm. Baby is then going to absorb mom's body heat, right? If anyone has ever taken care of a kitten before, right? They like to snuggle. Babies need to snuggle. Let the baby breastfeed. When you are resuscitating a newborn, the most important part is that you make sure that the baby's warm and then you stimulate them, right? Because there's plenty of steps that you don't necessarily have to take. Because if all you have to do is stimulate the baby to breathe, you can avoid steps 2 through 4, right? If you have to oxygenate, then you can prevent the other issues. Because no one really wants to have to actually work up a baby cardiac arrest. Like that's a lot. That's you're going home later. So if the baby is not meeting, good muscle tone, good crying, a good APGAR score, you're going to be working here in the no column of trying to stabilize and resuscitate the baby. So we talk about this inverted pyramid because we can, as BLS, you can do everything except for a medication. The number of times that you are going to be pushing epinephrine on a newborn during resuscitation is hopefully going to be like less than 0.01%, right? Like we don't want to go there. We want to make sure that we do all of these other things. Similarly to how pediatrics, right? Most pediatric cardiac arrests are due to a breathing issue. Same thing with babies, right? Ben, could you mute, please? So you want to make sure that the baby's warm, right? You're going to stimulate it. Best example I can probably give you. If you remember the scene in 101 Dalmatians where the last puppy is born and they're like, oh, we lost the puppy. And then he's sitting there and he starts rubbing the baby, or rubbing the puppy. That's essentially what you're doing in newborn resuscitation. Pretty much like identical. Perfect example, newborn resuscitation brought to you by 101 Dalmatians. You won't be moving down this pyramid. So like if you get the baby to start breathing on their own, you don't have to move on to oxygen, okay? If they don't breathe well, you're going to start ventilating them or you start giving them some blow-by, right? And if that doesn't start working, then you move to some ventilations, okay? And if that doesn't work and their heart rate is less than 100, you're going to move into chest compressions, okay? And then, of course, if that is still unsuccessful, medications, but we'll get to that momentarily. Now, remember, newborns have a totally different anatomical shape than adults because they got the big old pumpkin heads. Okay, so it's in order to line up their airway, you need to get them into a sniffing position. Okay, and that means that you're going to be propping them up a little bit. This is a perfect example of how you might use a towel and a blanket in order to ensure that the airway is appropriately lined. Okay, because you can ventilate all you want. If their airway is compressed because their head's in the wrong position, you're not going to do anything positive for the baby. There's meconium staining for you. Most of the time it's babies who are in distress and like kind of underweight babies. Okay, those are the ones who you'll see. Meconium is fetal stool. If anyone thinks it looks like bird poop, it's probably pretty close. Most of the time, meconium staining does need to be, I'm going to go back to this picture. Meconium staining does need to be removed from the airway, right? This is one of those times where you will be suctioning an airway. We will teach you the meconium aspirator, which you hook up. It's like this little tiny device that you hook up to the end of a endotracheal tube, where you tube the baby, apply suction using the meconium aspirator, and then take the entire tube out and then get another tube and do the same thing until you clear the airway. Because now it's a little bit beyond just like the oropharynx. You need to get into the lungs to make sure that the meconium staining isn't going to create pneumonia. Because think about it, if you got shit in your lungs, you're going to get pneumonia. These babies often present with very poor muscle tone and bad, like not great breathing effort, so you're gonna have to work them up. And here's the scene. Here's the scene from 101 Dalmatians, if anyone needed that childhood throwback right now. Only tactilely stimulate and rub the baby for about 30 seconds before you start to become more aggressive. Okay. You can evaluate the heart rate with either your stethoscope or, like we talked about before, right, the base of the umbilical cord. You can still feel a pulse. So you can kind of palpate a pulse there because, you know, they might be a little wiggly. It might be hard to get the brachial pulse. And skin color is a really good, will help you evaluate their circulation nicely as well. Here's your APGAR score again, in case we forgot it from last time. I'm not going to Mr. Sopa you. But when you are resuscitating a baby, right, you make sure that you have all your equipment set up, because Lord knows there's going to be times when you're like, oh, we don't have time to do this. But that's kind of when going and checking your truck before a shift is important. Did you bring in your OB kit, right? Do you need to warm up the baby? Cool. Awesome. All right. Is the baby breathing? No. Warm them, dry them, open the airway, right? If you have to, suction them. Are they breathing with a good heart rate? Yes. Fantastic. Here's some oxygen if they're cyanotic. If not, we can hang out, right? We can go back up to routine care. All right. Are we breathing? No. Heart rate's not. Are we breathing? No. Heart rate's not good. Ventilating. Okay. If we are ventilating the baby and it's not effective, you're going to have to intubate. Again, this is one of those more rare items that you're not going to be doing frequently. Okay. Is the heart rate more than 60? Yes. Continue ventilating. No? Oh, now we're doing chest compressions. In a neonate, you do not need to wait for the baby to be in full cardiac arrest with no pulse before you start compressions. All right, we are much more aggressive when they're brand new. So if their heart rate's under 60, you're going to start doing chest compressions. Okay, and make sure that you are effectively ventilating them, because sometimes they just need a little boost, right? They just need a little kickstart into life. So very good protocol for you guys to kind of look at. It follows with the protocol that we use in the city. Okay, so definitely start looking at those protocols to help tie together what we're talking about here and what you need to do in the field, because a lot of the resuscitation protocols follow AHA guidelines, and AHA guidelines are what you're going to kind of be tested on, and they're the golden standard. All right, so we talked about this already, right? Dry and warm, appropriately position the airway. Give them some oxygen if they're still cyanotic. And by cyanotic, I don't mean like their fingers are blue, because that can be normal. I mean like they have central cyanosis. Central cyanosis is really your determining factor one way or the other when it comes to oxygenation, not peripheral. Here we go. We're going to breathe, right? Positive pressure ventilation. Every 15 seconds, you can start to assess the heart rate, because you want to see if the baby is starting to do baby things on their own. Tubing. I think I only know one person who's tubed a baby. It's not exactly something that you stick a stork on the side of your ambulance for. It's not, we like to avoid that if possible. If there is meconium and you need to suction, then that is a very good reason to intubate the baby. Make sure that you also take into consideration if there's any congenital issues. Okay, so for example, diaphragmatic hernias, right, where the diaphragm is not completely closed and some of the intestines go up into the rib cage. You might have a difficult time ventilating that baby, but you might need to intubate in order to ensure adequate ventilation. Chest compressions, and again, you guys are going to go, and we're going to go through BLS procedures all over again. But in case you've forgotten, ventilate the baby first. If their heart rate remains under 60, then you are going to start doing chest compressions. Chest compressions are at a rate of 120 a minute and 1/3 of the anterior posterior diameter of the chest. You get them 1 minute of compressions before you then reassess the heart rate.
Nicole,
yes.
Could I just intervene real quick?
Sure.
In regards to intubating infants, it's very scary. I've had to do it numerous times. I've had to do the needle into the bone, and it was very scary. But you need to practice it, and you need to consider that if you have a baby who is pretty much dead, and you're going to try to revive them, you need to practice these skills. Don't be scared of them. Practice the skills, because your next patient might survive from those skills, the intraosseous and the intubation. So you gotta get it done. So don't be scared to do them. Thank you.
No problem. Exactly. Practice makes perfect. So if this is why we learn these skills in lab now. And if you have the opportunity to do CMEs and such in the future where you can refresh them, because I can't tell you the number of EMTs and medics I know who do not know how to put on a traction splint, because it's just on the ambulance. So if you very rarely are intubating or resuscitating a newborn, you're going to want to brush up on these things. And again, this is also why it's okay to check on your protocols on your way to one of these calls. I can't tell you the number of times we got baby not breathing, and my partner's driving, and I'm like reading the protocol off, like, all right, so remember, like, this is our epinephrine dose, this is what we're doing, like, this is the steps, and you get there and it's just a baby who maybe aspirated on milk or something, which is fantastic, healthy kid, right? But there's no shame in refreshing the knowledge of your protocols while you're on your way, because it is something that we do not use that frequently. When it comes to now moving on to more aggressive matters like epinephrine or volume, volume expanders really are kind of reserved if you do know that the baby has lost some level of blood, or the baby appears to be in shock. Okay, an epi is really indicated if despite ventilations and oxygenation and compressions, the heart rate remains under 60. Okay, so you need to be very cautious. Again, you have a brand new baby who isn't really going to be great at compensatory measures, so you need to be cautious with the volume expanders and the chloride fluids, because they can end up in the lungs just like they can with your elderly folks. A number of different post-resuscitation complications. Obviously, ET tube displacement, right? So in neonates, we do not use a cuffed tube because the narrowest part of the airway is where? Where? What? A little louder?
Trachea?
Yeah, down. It's funnel shaped, right? So where we have the adult airway, which is a little more evenly shaped at the beginning of like oh my goodness, the vocal cords, right?
Brian, do you know if it's the West Hampton Enterprise office? It's Riverhead. Got it. Thank you.
Joe, mute.
Sorry.
No problem. So you have that. You don't need a cup tube, right? Because it's not going to fit in that funnel-shaped narrowed airway. Tube occlusion. Again, if you have a patient who has meconium staining, this might be a significant issue. The biggest issue I'm going to say is pneumothorax. And we talked about this a little bit during our airway section when we had patients. We talked about using a smaller BVM, or the potentiality of using a smaller BVM to ventilate adult patients to prevent lung injury. You have this little teeny tiny baby with little teeny tiny lungs, and we have a relatively, for them, large BVM. So you need to be very gentle when you are ventilating. And this is one of those times where adrenaline is going to take hold of you, right? So you need to try to stay calm and make sure that you are not over ventilating the patient where you can, pop a lung, because that's, just going to complicate things a little bit more. But in terms of the ET tube being dislodged or the tube being occluded, it's exactly the same things that we are looking for when we are dealing with those complications in an adult patient. The only other thing is you might see that the patient has their bradycardia has come back, right? Because they're not going to they're not going to decompensate super fast, but their heart rate will start to drop.
Remember in Vinny's skills, he exactly what you said. And he also said just to remember to pop out that little cap. So
Yeah.
in case you are forcefully ventilating, that excess pressure can be released there.
Yeah, 100%. And this is that might be one of those times where I would not let a firefighter ventilate, because they do not have that level of training that we do. You want to ventilate an adult? Sure, knock yourself out. A little baby, I would hold on to that airway more than anything else, because they need, you need to be very careful and have a little finesse when you are ventilating.
Nicole?
Yes.
Just one thing you need to remember. Once you intubate a neonate, you're married to that tube. You don't let it go to anybody. You don't let it go to an EMT. You don't let it go to a fire department member. You're married to the tube. So you got to stay with that tube all the way to the hospital.
Yes.
And if you need to put some kind of multi-dressing around the neck to hold the neck in place, but you got to hold that head and you're married to the tube. Always remember that.
Yes, 100%. I'm just saying, so for example, maybe you have an inexperienced partner or something that you might have to hand off to in order to do something else. Because Lord knows, situations like that, people forget how to do what they're supposed to do. But
correct. Yeah,
adrenaline's a wild thing. It can either make you really effective or really ineffective. There's no in between, unfortunately. So asystole and PE are usually pretty uncommon in a newborn. Remember, brand new lungs, brand new heart, right? You're rolling off the lot with a brand new set of human bits. It shouldn't have a dysfunction like asystole or PEA. However, now we talk about pneumothorax. If you do not handle that pneumothorax and it becomes a tension pneumo, you may see PEA in a newborn. And that would be not only a result of hypoxia, but potentially your fault. So this is why we assess and reassess. A number of different other things can cause cardiac arrest, usually apnea, unresolved bradycardia, or persistent fetal circulation. Again, what are we doing? We're going to the hospital, all right? We are not going to dilly-dally on scene. We're going to move. I want to talk about, I think, Brianna, you asked how big are the little itty-bitty babies? About that big. I want to say that's about 25 weeks gestation. Give you an idea of how big it is, how big a teeny tiny baby is. And we talked about this already a little bit, right? If the baby is less than 25 weeks and has some sort of, is in cardiac arrest and you are unable to access an airway, you might not even need to resuscitate because it might be entirely futile. Usually a APGAR score of 0 after 10 minutes is a good sign of death in any newborn. I don't really know why that needs to be said, because an APGAR score of 0 is sort of like a GCS of 3, right? You don't really recover from that.
Are we still calling Medcom for IV access for newborns?
So, IV access in a newborn, usually you use an IO. And if you look at your protocols, the primary goal is transportation. REMAC question, directly quoted from the REMAC. What is your primary goal when treating a pediatric patient? Transport. They don't want you to start an IV. They don't want you to start an IO. You are to transport. Okay. For the most part, a lot of pediatric calls can be handled in the BLS fashion. I want to say probably other than a cardiac arrest or like a labor. The only other thing you really would be handling is a slightly older child who might be anaphylactic or an asthma attack, right? But even then, they want you to be transporting and doing all of your care en route. Number of different reasons for that, but ideally you want them to be able to have all of the care, because we can only do so much, right? A lot of times, like, kids are one of the highest groups who suffer from traumatic injuries, right? What are we going to do for that other than splint, really, right? They might need a surgeon more than they need us. So transportation is the number one goal of pediatric care, as per REMAC.
By the way, if you did your homework, that was in the homework questions.
So apnea comes in two different forms. You have primary apnea and secondary apnea. Primary apnea is usually self-limiting because of carbon dioxide, right? So as those chemoreceptors are like, hey, there's a lot of carbon dioxide going on over here, it will stimulate the baby to breathe, okay? It's a common issue with small children or small babies, right? This is where the stimulation will help kind of create them the urge to breathe. Secondary apnea, however, is caused, obviously, by a secondary source. So, was mom on narcotics? Is there some sort of respiratory muscle weakness? Is the baby septic? Right? So there's something else that you would need to investigate in order to find out why. Honestly, I want to say the only thing that you're really, potentially going to have to deal with, is the use of narcotics, right? Because we can give a baby Narcan. You can't give a baby antibiotics for septicemia, right? That's why we're transporting. We're going to let people who have way more school debt deal with this situation. Bradycardia, again, babies are very resilient, so if we fix the bradycardia relatively quickly, they'll be a-okay. A lot of the times it can be caused by prolonged suctioning, which is actually part of the reason that we no longer routinely suction a baby's airway. Though do remember, if you suction a baby's airway, you want to do the mouth first and then the nose. Babies are obligatory nasal breathers, so if you go to poke them in the nose, you'll stimulate their inhalation. Prematurity is always a huge risk for babies. They have very immature lungs at that point. They're not going to necessarily breathe well, and they have a whole slew of other risk factors that could potentially cause them to be in respiratory distress or cyanotic. So, just keep this in mind, and remember, transport is your highest. And Danny, back to IV. If you were having a newborn, you aren't going to necessarily go for an IV because it's going to be very, very challenging to find a vein on a baby. Up to about 3 years old or so, like about even 3 to 5 years old is really when they maybe start showing some veins. It's, again, it's a very difficult stick. IO, you're going to use an IO. That should be your primary vascular access if you need it. So sometimes you have a patient who might be experiencing hypovolemia. It could be due to trauma or dehydration or other hemorrhage, right, due to a challenging birth or a placenta abruption, etc. again, this is one of those situations where you might need to do an IO and do a fluid bolus, 20 milliliters per kilogram. Okay, that's, think about how many kilograms a baby is, right? Like 4, maybe, right? They're not particularly big. So 80 milliliters of fluid, right, is the trick. You want to make sure that you're not overdoing it. Babies also may present in shock even if they have a normal blood pressure. And now I want you to think about this also. How many times are you taking a blood pressure on a neonate? You know, it might be a skill that we don't necessarily excel at. You know, even the monitor might not be able to get a blood pressure. So you need to make sure that you're also aware of the other signs and symptoms of hypovolemia in a newborn.
Would you just take like put the little cup around their thigh or something with the monitor?
You could, yeah, you could. But honestly, like some of the modeling of the skin, or cool skin and extreme tachycardia, delayed capillary refill, those things are probably going to be more accurate than checking for a blood pressure.
Nicole, back to the intraosseous on the neonator, especially the neonator. Assuming you were doing that, I mean, I'm just contemplating that, and it's got to be obviously a little bit different than the adult. I mean, different size drill bit, different technique.
Same technique, different drill bit. You need to make sure, and you guys will do IO. Like we have a neonate leg that you're going to practice IO on. It's similar, yeah. You're going to use the pink gun, IO gun. Or if you are, as someone who works at Jamaica, the tiny jam shady. You're going to really have to stabilize that leg. One of the things you should not do is put your hand behind the leg, because there's a possibility of putting the needle right through and then into your own hand. And it's very, very gentle. But again, you guys will do that when you get to lab, practicing the small leg IO. Seizures in the
chicken wings is a thing.
Yes, I have 100% seen that. If you want to bring in chicken wings, I'm sure we can probably find some extra IO needles here and there to practice that with. Very similar in texture. The only thing you're missing is that like little layer of skin.
Okay. Nicole, they're chicken legs, not chicken wings.
Sorry.
If they want to bring in wings, I'll be more than happy to eat them.
There you go. Bring in the legs to put IO on, and bring in the wings for everyone to eat. Perfect day. Seizures are always considered pathologic in a newborn baby. That's not really something that they should, remember, brand new car smell. They should be good. Most of the time, frequent seizures are secondary to either metabolic or cardiopulmonary difficulty, right? So this baby might have a sudden drop in blood sugar. They may have sustained some level of brain injury during labor. Again, ABCs, most important. And then we don't carry phenobarbital, but if you have a baby who is seizing, you may have to call and get a benzo. I do believe you can do it on standing order, but that doesn't necessarily mean that you won't want to call medical control for maybe some guidance, because it's not something we see very frequently. Babies do not tend to have a fever, especially they're brand new. They shouldn't be sick, right? So if they have an elevated rectal temperature, this is something that is a problem. Mom may have had an infection that she's passed on to the baby. Neonatal sepsis is a huge thing. It's actually really funny because depending on where you give birth, if the baby has even one temperature of over 100.4, they will take them away from mom and monitor them and give them broad spectrum antibiotics, which it has been kind of determined that they can trend up like immediately after birth. So taking them away from mom is not necessarily the best thing, because they really should be breastfeeding, etc. But if they do have an actual fever, it could be a number of different things. Usually bacterial or viral infection needs to be taken care of. But what are we going to do? Make sure they don't seize from the fever and then bring them to the hospital. Hypothermia, right? Core temperature below 95 causes acidosis. Could also be a sign of sepsis, just like when we have adult patients who are very chilly, who are cold. I like to call it cold sepsis. Remember, wrap them up like a potato because that is the best way to keep a newborn warm. They have large body surface area, so they're not going to be able to do it on their own. Some of the signs and symptoms, obviously, a cool, pale skin. Bradycardia is a huge thing. Lethargy and irritability, right? Babies are kind of usually pretty easy to be soothed, especially when they're brand new, because they're like, this is fun. I like this. This is nice. New experiences. So if they're very irritable or lethargic, it's a possibility they're hypothermic or hypoglycemic. Whereas adults are less than 60, hypoglycemia in newborns is 40 milligrams per deciliter, 30 milligrams per deciliter for premature infants. Usually this is the baby who's a smaller twin or mom had has diabetes. So be cautious because, they're not exactly going to try to talk to you and like be confused. You're going to have to potentially play detective and find out why the baby is, lethargic or their eyes are rolling, which is usually a sign of a seizure in a young child. A lot of other different concerns that you need to, kind of pick up on that you aren't necessarily going to think of or have a lot of experience in seeing. So this is why it's important to regularly brush up. Mucus. Vomiting mucus is kind of normal in the first few hours of life. Babies don't generally vomit. They'll spit up, okay, right? They won't be doing like a Linda Blair exorcist projectile vomiting. They don't have the abdominal muscles for it, right? So they kind of just spit up and it kind of dribbles. But if it's like ongoing vomiting, that's usually a sign of a small bowel obstruction, and or like a drug withdrawal, so that can also be an issue. A lot of new moms do not know what is normal in terms of what their baby's poop should look like, right? Especially the first few couple days. That's like the window where moms, or brand new moms, kind of freak out the most, and will call 911 because they don't know what's right? So my baby's pooped like 5 or 6 times today. Is that normal? Yes, totally normal. It should be kind of liquidy because think that they're kind of on a liquid diet. It's commonly very green. I'm sure if you talk to any of the parents in this class, if you have never had your experience with children, that they will explain to you all of the varieties of fun that one can find in a diaper. But, if it's more than that, or mom has noticed, or mom or dad, I won't be sexist, mom or dad has noticed that, the baby's bowel movements are very foul odor all of a sudden, or they are a different color or consistency or more frequent, that can be a huge sign of another issue, okay? And that's, again, we are not going to diagnose it. We're going to give supportive measures and go to the hospital, and let everyone figure that out. Newborn jaundice is a very common thing and very easily treated. Usually the liver just needs a little more time to kind of catch up. Most of the time they'll put the baby in this really nice UV tanning bed and they just UV them for a little while until they are their bilirubin drops. I don't really know why the UV light works, but it's fantastic apparently. The only thing that would be better if someone gave the baby a tiny little like mixed drink with an umbrella in it, like that. Just the kid looks like he's having a blast. A lot of issues or a lot of risk factors are prematurity. Asians and Mediterranean descent have a high risk of newborn jaundice. Again, if it's handled appropriately, it's not a big deal. If mom or dad is suddenly freaking out because their baby's looking very yellow, this is something you could potentially call like, it's very possible that it's just newborn jaundice, and hopefully it's none of the more serious causes of jaundice. Obviously, babies are high risk for infection. Babies who are breastfeeding are at a lower risk of infection because they're still getting mom's coverage from mom's immune system, okay? A lot of the times, those first, couple weeks, baby is going to be really safe from a lot of various infections, provided that, one, they're breastfeeding, and two, they're not being exposed to someone with something really funky, right? Most of the time, mom or dad is going to say, like, something's not right with the baby, okay? Lethargy, irritability, kind of disinterest in suckling, also very, very good signs that something's not quite right. Again, are we going to diagnose it? No. We are going to treat the symptoms. We're going to recognize the symptoms, treat the symptoms, give supportive care, and get the baby to the hospital. Birth injuries are common. Hopefully it's not due to anything that we have done. Most of the time it's due to baby being a little too large for the opening with which it's about to depart from. Pulling on a baby's head is dangerous, right? You can cause spinal cord injuries. They could have all sorts of different intracranial hemorrhaging, again, from being forced out of a hole that's too small. If anyone's seen a baby who has the really fun foam helmet, right? Because maybe the baby's, the baby skull is not fused. That's why they can make it out through the birth canal. But sometimes they get a little cone shaped, right? Could cause other injuries, damage. Shoulders and clavicles are probably the most common birth injuries. Again, you'll kind of see if the baby isn't able to move one arm, it could be because their clavicle broke on the way out. So, right, there's a Zika baby with their microcephaly, right? A number of congenital abnormalities do exist. Some of them are genetic, some of them are caused by infection or drug use. Choanal atresia is a blockage of the nasopharynx, right? And remember, we talked babies are obligatory nose breathers, so if they aren't able to breathe through their nose, they are going to have an issue in terms of breathing. They're going to have issues when they're nursing, right? So the baby might become hypoxic while feeding, and just have like this ongoing issue. So something to keep in mind. Another fun birth defect that's a possibility is tracheoesophageal fistula. That's where the esophagus fused to the trachea, so the baby might have a difficult time swallowing, right? Because now it's not going, the food is, or breast milk or milk in general is not going into the stomach. With trachea, now instead of having a direct access to the lungs, it could be putting air in their stomach and then, ongoing bloating. Number of issues that, probably be diagnosed and surgically fixed, but hopefully before you have to deal with it. Cleft lip, palate, incomplete closure of the baby's like frontal lip and the hard palate is a possibility that the brain is exposed in the upper palate of the mouth. So this is a baby who you may want to be very cautious about when you're intubate, if you need to intubate. Difficulty with feeding and speech. These babies very often end up getting a number of surgeries to close, the cleft lip. PR Robin sequence, the baby's born with like literally no chin, so therefore you have a very large tongue in a very small space that can cause airway obstruction, especially because now that you have less chin going on, that tongue is attached further back in the airway, which again causes issues in terms of feeding and breathing. Cardiac anomalies, we talked about a number of these already. So, if you have the patent foramen ovale, right, you still have that mixing of blood in between the right side of the heart and the left side of the heart. You might have a coarctation of the aorta, where the aorta is significantly narrowed, which makes it very difficult for the heart to pump blood to the entire body. A patent ductus arteriosus, again, you have mixing of the blood, but this time it's not within the heart, it's externally from the heart, so the blood's going from the aorta back into the pulmonary circulation. You have tetralogy of Fallot, which is 4 different issues all at the same time. And while it sounds really bad, the fact that these 4 issues are going on is actually why the baby can survive for as long as they do. So you have a patent foramen ovale, or just an overarching ventricular septal defect. So you have this extensive blood mixing between the right side of the heart and the left side of the heart. The aorta, because because of the big hole in the ventricular septum, the aorta opens up lower, which means that it's now accepting blood from both sides. Okay, so that protects the baby from the fact that their pulmonary valve is stenosed, which means they're having a harder time getting blood to the lungs for oxygenation. So the oxygenated blood that's coming back is kind of inadequate because this is not enough getting there, but because the blood is mixing, they're able to kind of hold steady for a little bit longer until the surgery can be done to fix this whole issue. And now because the pulmonary valve is stenosed, the right side of the heart starts to become overworked and gets larger. So collectively it's not great, but because all 4 of these things exist together, that prevents the baby from like immediately dying. Left right shunt, this is the patent ductus arteriosus right here, just in a slightly bigger picture. So as you see, the blood from the aorta goes back down into the pulmonary circulation, so it mixes the blood and you don't get as effective oxygenation of the blood, while also overloading the left ventricle because of the extra right-sided return. Narrowing of the aorta, right? So now you're putting, again, more strain on the left side of the heart because it now has to push against the defect. The hole in the heart, right? There's plenty of people who live well into their 50s, 60s, etc., who have the potentiality of like a septal defect. It could be if it's a small defect, they can live for a very long time without ever knowing it's there. They just might get short of breath during, high exercise or stuff like that. The problem with that is also for an increased risk of blood clots because of the mixing. Usually you get a very loud heart murmur if there's a very large ventricular septal defect. We talked about this already. And a lot of the heart defects, the compensatory mechanisms creates blood mixing, but it also, it makes the whole heart anatomy of the heart look different. So if you have a large ventricular septal defect, if the aorta opens up a little further up, it eliminates this the variation between the pulmonary artery and the aorta. So you have mixed blood going both to the lungs and to the heart, to the body as well. Okay, usually they'll have like very early heart failure if they haven't caught this beforehand. A lot of times, if a woman has been getting really adequate prenatal care, a lot of the times they'll either have already addressed or diagnosed the issue, or sometimes they're starting to do this more and more now. They've actually gone in and they'll do heart surgery on the baby while they're still in utero. You can also have valvular defects if the baby's born with a variety of things. You can either have stenosis or regurg. You cannot have both, as told to me by a cardiologist. Okay, so a stenosed valve does not open all of the way, which forces blood back up the other direction, where a regurgitating or incompetent valve, it does not close all the way, which it means that the blood's going the opposite direction, going backwards as opposed to, it's going backwards with a little more lackadaisicalness to it. Remember that atrasia means that it's closed, all right? There is no hole where there should be a hole, okay? So usually there's a smaller, when it comes to ventricle or valvular issues, there's a smaller hole because of the lack of the various leaflets of the valve being, separated. Hypoplastic left heart syndrome, very small left-sided heart, underdeveloped, body doesn't get a lot of blood, so just hard. Really, the most important thing for you to kind of understand is the tetralogy of Fallot, okay, and the differences between the or like how the, how do I put this? How the heart malformation is then compensated for, okay? Just even though the baby's heart is not necessarily appropriately shaped or appropriately built, the ongoing failure to be a good heart actually helps the baby survive. So we talked about this already. Not gonna beat that dead horse, but I'm just gonna leave that up so you guys can take those notes a little bit. You can pause it later if you want. This is 3:14 in the recording, so if you want to come back to that. So what you will notice is that babies or young children who have tetralogy of Fallot that have maybe not been diagnosed right away, which is becoming more and more rare, will have what they call tet spells or tetralogy spells, where they start to become cyanotic. Basically, it's a lot of the times when they're when they're doing something over and above, right? So they're crying, or they're feeding, or they're having a bowel movement, or the baby isn't getting enough oxygen to keep up with the demand that the body wants while they're crying or feeding, and they start to become cyanotic and irritable, and can also become unresponsive. Transposition of the great arteries, another one that's usually picked up on ultrasound prior to birth and is commonly now fixed in utero. Rather than oxygenated blood going to the body and deoxygenated blood going to the lungs, the aorta and the pulmonary arteries have swapped, so you are just returning oxygen-rich blood back to the lungs, which really, the only way that this baby will survive for any period of time outside of the uterus is if there is either a prolonged presence of the fetal circulation, which is the patent ductus arteriosus, and the patent foramen ovale, or a significant ventricle septal defect, right? Because now that blood mixing will allow oxygenated blood to actually get to the rest of the body. Otherwise, demise is imminent. Anomalous pulmonary venous return, another rare birth defect where they are not the pulmonary arteries are not actually connected to the heart properly, so it bypasses things. Again, most of the congenital heart defects will be, you will kind of see that the baby is not feeding well. They're very lethargic. They're not growing. Maybe they're cyanotic on the regular. You're not going to necessarily be diagnosing that the baby has a total anomalous pulmonary venous return, but you will know that the baby does need ventilatory and oxygenation support. Occasionally, you will see babies who do have some levels of congenital dysrhythmias. Sometimes the AV node or the bundle of His is not appropriately placed. AFib and flutter is common. WPW, reentry, tachycardias, rarely heart blocks. Again, you'll see an irritable baby who maybe is cyanotic, who maybe needs some level of support, etc., etc. Other congenital defects that you may interact with, but probably rare. Intestinal malrotation, again, you're not going to necessarily be able to determine this. You might just have a colicky, finicky baby who you're dealing with, and mom's like, the baby isn't doing, like something's wrong. Baby might be hot to the touch because of sepsis, because of that intestinal malrotation. Pyloric stenosis, right? Baby's going to have a regurgitation issue. Might be on, Pepsid or a number of other things to kind of help reduce stomach acid and to see if that pyloric valve at the top of the stomach starts to loosen up as they get older. Diaphragmatic hernia will be usually noticeable upon birth, right? And that, again, that's having those on the left side where the esophagus goes through the diaphragm. The intestines pop up into the chest wall, where you would have a baby with a very flat abdomen and intestinal sounds in the chest. Spina bifida, again, you would probably see this upon birth. The baby might have a little, oh, here we go. Baby might have a little piece of the neural tube sticking out, but I'll show you a picture of that in a second. Again, intestinal malrotation, right? It's twisted. Baby's going to be colicky, diarrhea, not, perhaps jaundiced, not doing well. Here's the pyloric stenosis right at the bottom of the stomach right there. If the muscles are overgrown in the infant, when they feed, all that stuff is going to stay in the stomach longer and then will pop up. Baby will have very forceful vomiting because they are unable to empty their stomach. And usually it's accompanied by dehydration symptoms, which is something that we could potentially fix if necessary. And again, this is something they kind of usually grow out of because the rest of their body catches up to the overgrown muscles. Diaphragmatic hernia we talked about. Here's a nice picture, right? You see the intestines and the liver start to kind of squeak up into the thoracic cavity and kind of crush the heart and lungs. So baby might have a really difficult time breathing. Much like everything else when we talked about with babies, gravity is your friend, right? So if you sit the baby up, hopefully some of that pressure will be relieved. The abdominal organs might go back to where they're supposed to be. Some of the other signs would be like an irregular chest wall, or the heart sounds are not in the right spot. We don't really do a lot of OG tubes in the field, but it's a possibility. Not recommended that you do BVM. For some reason that the baby is born with an incomplete abdominal wall, you may be required to protect a portion of unprotected intestines, usually right around the navel region. Again, much like any other evisceration, you're going to keep it warm and moist. Whereas gastroschisis is next to the navel, ophilos, I can't say it, and I'm not going to try. This is actually through the umbilical cord, so the intestinal organs will herniate through the umbilical cord. I do not recommend cutting that. Again, more on the rare side. Spina bifida, this is what we talk about where we say take your folic acid. This folic acid helps prevent neural tube defects, mainly being spina bifida. It could happen anywhere along the spinal cord, but part of the spinal cord actually grows outside of the spine, which means that the baby could have all sorts of risk factors for paralysis due to the fact that that is no longer protected. There's different levels of spina bifida, but again, just kind of understand that there might be, I think I have a good picture. Yeah, there might be an exposed portion of the neural tube. Okay. And again, you're going to make sure that it's dressed with a sterile dressing. Make sure that the baby, you're not putting a lot of direct pressure on the area to protect the exposed spinal cord. And that's it. That's our, what was this?
Nicole, can I borrow this form just for 2 seconds,
Yep.
very quickly? Anybody who does not, can anybody identify themselves who does not have their FEMA certs done yet? Does everybody have their FEMA certs done? Okay.
See a lot of nodding. That's fantastic.
Yes, because if you don't have it done by Wednesday morning,
you won't be dismissed. That's all there is to it. You don't have them, you're going to be dismissed.
Looks like, thank you, Frank. And that's what I was going to say. And that's been the warning and the admonishment. So everybody has it done. Please don't forget to bring it. Okay. I think that was it. I might have had a question, Nicole.
Go ahead.
I forgot.
Oh.
Yeah, directly to, the rotations. I know we do OB-GYNs, but do we get any chance to rotate through any neonate wards at all? Like I see it, like the NICUs?
No, not that I believe.
Okay. All right.
You do the OBGYN and you should see your newborns there.
Okay. Gotcha.
Unless you happen to be that black cloud who just babies drop from the sky while you're on ambulances.
That could be me.
Oh, Lord. Okay.
Nicole,
All
just
right.
hang out for a little while. I need to speak with you also.
Sure.
So does Scott.
Okay.
Thank you.
All right. Adios, Nicole. Thank you very much.
Bye, guys.
Thank you.